Yes, ma'am. Yes, ma'am.
Rachna, you can start.
Yes, ma'am. Hello, good afternoon, all. I, Dr. Rachna Jaju, welcome you all on behalf of Foxy ICOG for
Rachna, you are muted. We can't
You
hear
are
you.
muted, Dr. Rachna. You are muted.
Oh,
Yeah, now it's okay. Yes.
yes. Hello, good afternoon, all. I, Dr. Rachna Jaju, welcome you all on behalf of this Foxy ICOG certification course on family planning, pregnancy by choice and not by chance. We begin with
So,
an official prayer.
Rachna, there is an echo beta, so you can probably switch off one device. Okay. You can proceed. Yeah,
Can we have the song?
yes, can we have the invocation song, please, to seek the blessings of the Almighty, please?
Yeah, sure.
Yes, ma'am. Yes, ma'am.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you. And with the blessings of Almighty, we proceed ahead for the presidential address by Dr. Sunita Tanulwadkar, Madam. Has Madam joined?
Madam, yet to join. You can go ahead with sir.
You can proceed to say a few words about Parag sir and welcome him to address the gathering. By then, Dr. Suvarna will join, I think.
So,
Can we have the CVs, please? Can you show us the CVs?
it is an honor for me to have the chairman for ICOG, Dr. Parag Biniwale sir. He's an illustrious chairman. Parag sir is always smiling, humble, and very easily approachable. And hence he is loved by the young brigade and is most sought after. So he frames wonderful signature projects and makes sure that the youth brigade is being involved. And he also this also shows that his commitment to hire in new raw talent and create great speakers for the future. So we request Parag sir to give his blessings to us.
Thank you, Rachna. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to address and welcome you all on the first day of the certificate course on family welfare. And this time we've titled it differently: pregnancy by chance, by choice, and not by chance. Rachna, my affection with the youngsters started when I became chairman of the Young Talent Promotion Committee, and that is how it has been. Because whenever we see you youngsters making a presentation, we realize that we are becoming older day by day, and then we have to learn a lot of new things from you. First of all, I must compliment the conveners who've taken great efforts. Dr. Shobha Gudi, who's our governing council member, Dr. Rachna Jaju, who also chairs the Family Welfare Committee of amongst the Maharashtra state, and our governing council member, Dr. Durga Shankar Das, and the coordinators, Dr. Kavita Agarwal and Dr. Riju Chimote. Family welfare is something which is close to the heart of everybody who is sitting here, and I acknowledge presence of past chairperson of ICOG, Dr. Mandakini Meg, who in fact was the first one to initiate a certificate course during the COVID times on the family welfare. Though we had to limit the working, it was initially meant to be a physical in-office course, but then we had to switch to the online mode. And since then, we've learned now our ways to manage all the programs online. For next 3 days, I'm looking forward to some interesting sessions. Family welfare is such an important aspect of OBGYN training, and I hope and pray that all the faculty will inculcate the nuances of this particular subspecialty in the minds of the viewers and the youngsters, especially, so that it eventually translate into welfare of women. Thank you very much and happy learning to everyone.
Thank you so much, sir, for those kind words. We now move towards few words from our Secretary General, Dr. Suvarna Khadilkar, madam. If madam is joined.
Yes, madam, I joined.
Yeah, ma'am.
I just heard Parag's address, and I can see such a huge attendance for this, very well curated program. And I must appreciate the initial efforts by Dr. Mandakini Meg when she started all these certificate courses, and very ably taken ahead by so many chairpersons after that. And this chairperson, Dr. Parag Binivale in particular, and Sarita Balerao are also taking a lot of efforts in continuing the same ahead. And contraception, as Parag said, is very close to everybody's heart. And I always feel that pregnancy by choice and not by chance is the most important way to save lives and reduce maternal mortality. Because if you see that in illegal abortions are the one of the major proportions to it's a bigger killer of women who go to the quacks and get the abortion done if they don't if they land up in unwanted pregnancy. So to prevent each and every unwanted pregnancy by judicious use of contraception is most important. And if you don't use that, they'll end up in unwanted pregnancies. Then they don't want to go to the doctors. They go to the quacks. Then it endangers their lives, and that contributes significantly for increased maternal mortality. So I have personally been a great I won't say fan, but I'm great, advocate of injectable contraceptives. And that goes a long way, because the most important phase of unwanted pregnancy comes around the time after a normal delivery happens, and the patients are in lactation and they have not accepted any kind of contraception, and they come back with the unwanted pregnancy. And like usual, I said, those days the respectful maternity care was not practiced. And I remember all my residents, everybody used to shout at them, see, you refused a copper T, see, you refused this, so you have landed in unwanted pregnancy, and we will not do MTP now. And they send the patient back. And these are the patients who go to the quacks. These are the patients who go to other, doctors who are not qualified to do the MTPs, and then they, endanger their lives. I think it's a very sad affair of state of affairs, and I think we have to prevent each and every unwanted pregnancy. And this certificate courses like this, I'm sure, will teach everyone, all the attendees, how you should practice the contraception, how you should advocate, and how you can give the wide basket of contraception to the users. And I think that's the best way to go ahead with the saving women. And every unwanted pregnancy prevented will save life. So thank you so much for inviting me here, and I'm really grateful for the all the good work that ICOG is doing, and thank you so much for the all the efforts that you take. Thank you.
Thank you, Suvarna.
Thank you so much, ma'am, for those kind words. We also have blessings from our chairperson for ICOG, Dr. Ashok Kumar sir, chairperson-elect Dr. Sheila Mane madam, and secretary of ICOG, Dr. Sarita Bhalerao madam. They have given us unwavering support for this certification course. I now call upon our very own Dr. Shobha Gudi madam, who is the convener for this course, and also madam has crafted this course beautifully. Her dedication to the field of OBGY is unwavering. She is a true teacher in all regards, and madam will guide us about this certification course and also give us an overview of day one for us.
Thank you. Thank you, Rachna. Thank you very much. And can you stop the slide share for a few minutes? For 1 or 2 minutes, please. Yeah, thank you very much. So a very good afternoon to all of you. Welcome to this certification course. And let me begin by placing my heartfelt thanks and gratitude to Dr. Sunita Tendulkar, the president of FOXI, and to dear friend and a great a really great thinker, I must call him, Dr. Parag Beniwale, the current chairperson of ICOG. And I have been associated with him for many years, and I can see that he really has a vision for women's healthcare, and that is what has kind of come to play in his year of chairpersonship for ICOG. We can see wonderful programs from ICOG, and we really thank him for giving us this opportunity to conduct the certification course on contraception and family planning, which is much needed. We also really thank Dr. Suvarna for coming in now, and also Dr. Sarita Bhalerao. So this 3-day course will be of 3 hours each. And we have tried to have a very comprehensive cover of all aspects of contraception and family planning. And as everyone's talk is started to build up, we can see the passions kind of, reflecting on the fact that there is a huge lacuna in this field of service. And every OBS and gynae specialist should look forward to improving our skills for talking about contraception, offering the basket of choice, ensuring uptake, follow up, and ensuring that there is no discontinuation. So we have tried to bring in enhancing the basket of choice, the government program, how it is working, where exactly does India stand for population stabilization, what can be done to improve uptake, how best effectively to bring in the medical eligibility criteria in everyday practice, how best it can be utilized, how can we offer women in vulnerable state and in high risk situations the best contraceptive basket, how can we fine tune our procedures and techniques for delivering these services. And finally, we will also have a very good session on kind of, on medical legal aspects of this service, and also on establishing a service with all its finesse and all its minuscule details of having a counselor in place, of having IEC material, etc. So we look forward to all this and much more in all these 3 days. So now I hand this over back to Rachna to start the first session. And I do hope that the president would have joined to give her address by now, because we are missing her. So has Dr. Sunita joined? Okay. Okay, Rachna, you can take this forward. Yeah.
So moving towards our session 1, the academic session. We have co-conveners Dr. Durga Shankar Das with us, and our coordinators for this certification course, Dr. Kavita Agrawal and Dr. Riju Chimote. So moving towards this academic session, for the first session we have Dr. Hiralal Konar sir. He is the past chairman of FOXI ICOG in the year 2013, and he is president of ISOPARAG right now. He is past president FOXI and FOXI representative to Asia Oceania Federation of Obstetrics and Gynecology. We welcome you, sir. Our second chairperson for today is Dr. Mandakini Meg, madam. As rightly said, she is the pioneer who has started this family planning course, and she is the past chairperson of ICOG FOXY in the year 2020-21. She is president of the Association of Medical Women in India, Central Council. She is recipient of multiple awards and delivered multiple orations. We welcome you, madam. Now I request Dr. Konar sir to introduce our speaker for today, Dr. Ratnamala Desai, madam.
Thank you very much. Welcome everybody. At the outset, I express my sincere thanks to the FOXY ICOG leadership, Dr. Sunita, Dr. Parag, Dr. Subarna, Dr. Professor Ashok Kumar, Dr. Sheila Mane, and Sarita Valera, the Secretary General of ICOG, especially the conveners like dynamic leadership of Dr. Shobha Gudi, Dr. Durga Shankar, and Rachna, obviously the coordinators. Thanks to everybody. This is really a wonderful session. I was wondering, 3 days program, really very interesting, covering all the minutes of that of the contraception. Moreover, I love the title of this program, Pregnancy by Choice, Not by Chance. With permission, Dr. Shobha, Dr. Durga, and Dr. Rachna, I like to add one word, pregnancy by choice and not by chance, not due to non-availability. My experience with this subject is quite long, because since my beginning of my registrarship in North Bengal, we did 23,000 cases of laparoscopic sterilization, published in the FOXY journal. Anybody interested can go through that. My interest, again, coming back to Calcutta on vasectomy, good number of cases, and we published in that of the, again, FIGO journal, well accepted. And last part, I did with that of the research work, Dr. C.N. Purandare, IUCD, silver versus the copper T. Really wondering result, and all published in the FIGO journal. With this introduction, I feel to introduce, and I feel really honored to introduce one of our senior colleague, Dr. Ratnamala Desai, Professor, I believe. Madam, I have met you somewhere, in your institute, maybe as an inspector of MCI or the DNB, maybe at your institute. Really, we are happy to have
Yeah.
you.
हीरालाल सर, हीरालाल
Yeah.
सर, 1 मिनट अगर एक और चेयरपर्सन को भी हम इंट्रोड्यूस कर लेंगे मैडम को, फिर हम स्पीकर
Really, carry on,
have we
carry on.
introduced Dr. Mandakini Meg?
Yes, ma'am.
Have we introduced?
Yes, ma'am.
Yeah, she has done. She has done.
She has done. Okay, fine. Okay, sir. Please
And,
continue. Please continue.
And to talk about Dr. Mandakini, that she is our colleague, first chairperson of ICOG, and mainly that with all the ICOG FOXY members, I am well acquainted with family over the years. 1981, when I was a medical student, I was introduced in
Yes,
FOXY
yes.
membership, and I
Correct.
continue to that. Thank you very much.
I think
wish-
many who are practicing family planning today for their patients and contraceptive advice, they have been Mandakini Meg ma'am students, and we thank madam for joining. In particular, I think it was remiss of me. I could not mention that it was madam who started the certification course, and because of that, madam, today we are very grateful that this particular subject has got a highlight as a certificate course of 3 days. And thank you so very much for blessing this particular field of service. And we look forward to your comments as a chair in the next session. So I will request Dr. Konar to now complete the introduction of our stalwart faculty today, Dr. Ratnamala Desai.
Well, as I have already introduced, madam, that I have met you in your institute as an inspector of DNB long years before now. Well, madam is principal SDM Medical College, Sciences, Dharwar, chairpersons FPA India Dharwar branch, national president FPA India, country coordinator Geneva Foundation of Medical Education and Research, Geneva member board of trustees IPPF London. I believe madam will do a lot of information for all of us. Will you all the best, madam?
Thank you so much. Baba, I want to mention here, thank you very much for remembering me. I want to mention,
Yes, madam.
when I took over as the chairperson of the ICOG in 2020, there were 2 courses because it was going to be physical courses, and this was the course which was passed by all the council, everything. And I think I have approached you also that you were also one of the key persons in the
Yes, madam.
formulating that course. And this course, 3 days course, physical course, and the violence against women, these were the 2 courses very much appreciated. And we were about to start physically. But as Parag has mentioned very correctly, instead of physical, it became the online. But these 2 courses were the foundation of all the ICOG courses.
Yes,
It is
yes, we
very-
indeed remember that, madam. Yes.
So you were a part of it, and of course,
Thank you.
Parag was there. So please continue. Your
Thank you, madam. Thank you for inspiring all of us so hugely. Your life has been an inspiration for us. And Desai ma'am, please share your screen, please.
Slideshow.
Madam, full screen, please.
I'll do it. Good evening, ladies and gentlemen. I thank the organizers, particularly Dr. Parag and Dr. Shobha and all the ICOG members for having invited me to give a talk on unmet need of contraception in India. Thank you, Dr. Kona, for remembering me. It has been more than 15 years that you visited our institution, and you must have inspected hundreds of institutions by now, but you still remember. I appreciate. Thank you so much. Thank you, sir. So, talking about unmet need of contraception, it's defined as women with unmet need are those who are fecund and sexually active, but are not using any method of contraception and report not wanting any more children or wanting to delay the next child. So they either want a spacing method or a limiting method. The concept of unmet need points to the gap between the woman's reproductive intentions and their contraceptive behavior. She needs a contraception, but she has either no access to it, or she has some social barriers to use a contraceptive. So this is the definition where actually she wants to use the contraception method, but either she has no access or she, for whatever social reason, she's unable to use it. Now, there are different types of unmet methods. The unmet method for spacing, where she wants postponement. She doesn't want a limiting method, but she wants postponement. The need is about 4%. And when she wants limiting method, that she does not want any more children at any time, that's 5.4%. So the total unmet need for India right now is 9.4%. This is as per the NFHS 5. So the spacing needs are more relevant to younger women. Now, there has been a national decline overall for the unmet needs for family planning. It is from the NFHS 4 to NFHS 5, it has declined from 12.9% to 9.3%, which is a good decline. And there is significant improvement in the last 6 years. And it reflects the broader prospective trend in reproductive health. Now, there are many reasons why there would be an unmet need for family planning. There could be method-specific barriers like access, or the perceived effectiveness and safety, or the actual side effects of use, or the perceived side effects, appropriateness of this method, or the familiarity, or the ease of use, and so many other reasons related to the method per se. Other than the method, there may be a generic disapproval of pregnancy prevention, or there may be a weak or inconsistent or ambivalent fertility preferences, or there may be a partner-related factor, or there may be a perceived low risk of getting pregnant. So there are multiple factors why there is an unmet need for family planning. There are also many regional variations. But over the past 5-6 years, the northeastern states, which had a very high unmet need, have shown most dramatic improvements in the last, compared to NFHS 4 to NFHS 5, where Manipur showed 17.8 percentage point decrease, Nagaland showed 13.5 percentage point decrease, and even Sikkim showed 9.1 percentage point decrease. There are many geographical variations, as we know, because we are a diverse country. There's substantial differences across states and union territories. The southern states show lower unmet need compared to the northern states. The probable reason being that there are higher number of female sterilization rates in the southern states and also more effective family planning programs, while as the northern states continue to face greater challenges. Now, over the last, after the 2021, over 24 million women have unmet need, and 50% is contributed by these 4 states. The unmet need of the women is contributed 50% by Uttar Pradesh, Bihar, Maharashtra, and West Bengal, while as the other states are relatively less. Now, coming to the age, the highest unmet need is among the younger women. The younger women between 15 to 19, the unmet need is about 17 to 17.8%, while as between women aged between 20 to 24, it is 17.3%, and is also high amongst the elderly women, perimenopausal women, it's about 40 to 49 age group. Now, what is important? What is a crucial role? What is important, which decides, what is a critical role which decides the woman's preference or the unmet need is the years of schooling. It is said that education plays a very critical role. The number of years of schooling is also important because it significantly affects the family planning, because there's a positive association with education and understanding of contraceptive needs. And the female literacy is crucial in higher contexts. Now, there's also a difference between the urban and rural women. Rural women show higher unmet needs. The spacing need for rural women is 4.3% versus urban women, which is only 3.5%, whereas the limiting need for rural women is 5.6%, whereas urban women is only 4.9%. So it's the rural women who have got a higher rate of unmet need. Socioeconomic factors also play an important role. The highest number of unmet need is lowest in the socioeconomic groups, in the lowest socioeconomic groups. They have a high unmet need. And the number of children also plays an impact on these decisions. Now, considering the demand satisfaction, 87.9% of contraception demand is satisfied, but this satisfaction is lowest in the adolescent age group, that is 15 to 19 years. And as the woman's age increases, the satisfaction, but so that signals us that we should concentrate more on the reproductive health needs of the adolescent, and particularly the contraceptive needs of the adolescent women. Now, there is an important role of health workers as well. The frontline health workers are very important because they are the ones who talk to the women in the rural areas. They are the ones who are part of the community of where the woman lives, and the women in the community listen to the frontline health workers in the villages, and these women are the ones who bridge the gap between the knowledge of this contraceptive and also the use, and also they will address the concerns about the side effects. So the frontline health workers form an important bridge for us between the woman in the society and us. Now, the key predictors which are identified for unmet needs are the education level. Higher the education level, lower is unmet need. More she's in the urban area, less is the unmet need. Religion also plays an important role. The caste plays an important role. The wealth index plays an important role. Antenatal care visits. If she has got regular antenatal care visits, probably she's more receptive to our advice on contraception. Now, what are the recommendations for action? It is important that we strengthen the National Family Planning Program. We develop targeted state-level policies. And as I mentioned, we have to focus on younger women, the lowest wealth quantiles, and also improve the spacing method awareness. Now as we are promoting smaller families, it becomes extremely important for us to delay the first child and space the second child. And also it is extremely important that we stress more upon the long-acting reversible contraceptives rather than the permanent methods. Now, ethical considerations are extremely important. We should avoid coercive family planning measures. There's nothing like compulsion. We have to respect women's reproductive choices. I just now heard Madam talking about how we were not so respectful to a woman about her reproductive choices. But it's very important that we should treat every woman with respect. We should know her reproductive choices and we should accept and respect her choices. And we should always ensure informed consent and provide comprehensive reproductive health education. We should educate a woman about her reproductive rights, as well as we should educate her about the options and choices which are available. But we have no right to compel any woman, or we don't have any right to coerce a woman to use a particular method. It's extremely important to increase the male participation, because the whole burden of the family planning most of the time is taken by the woman, and it's important to involve the male partner, talk to the male partner, call him, involve him in the antenatal care, involve him during labor process, involve him soon after delivery, involve him about explaining to him about all the methods, the effects and the side effects, and the efficacy of each method. So it's very important to have a detailed discussion with the male partner as much as the woman. So we have to involve him in taking the decisions, creating awareness, and see that it is his responsibility as well. If it is the reproduction of the family, and it is not only the reproductive function of the woman, and it is very important that the male participation is also completely the male partner is involved. The future research directions, particularly the socio-cultural drivers, play an important role in contraceptive uses. We have all seen that mothers-in-laws are the ones who make important decisions many a time. The woman has no say, no choice. She has to listen to her husband's choice. So we have to take all these people into confidence. Community health workers are very important because they were the ones who talk to the woman every day, and we focus on the user experience. So how can we research, improve healthcare delivery? So we have to do continuous monitoring of the unmet needs, adapt strategies based on changing demographies, recognize diversity across regions, and prioritize women's reproductive autonomy. So the key takeaways are that significant decline has happened between NHFS 4 and NFHS 5. The targeted interventions are crucial, where we should focus on young married women, lower socioeconomic groups. Education is important, and frontline health worker support is also very important. So key takeaways again are significant progress has happened in reducing unmet need. Regional variations are there. Targeted ethical interventions are absolutely necessary, and the goal should be zero unmet need by 2030. Ladies and gentlemen, these are my references, and thank you very much for this opportunity. Thank you so much.
Thank you very much for that wonderful, highlight of the very important subject, that is the unmet need of the in contraception. You said very, very rightly, madam, that we have reduced, the demand is reduced. from
Madam,
the-
you are not audible
Oh, I'm not audible?
clearly, not clearly audible.
Volume is a
Volume
bit
double
low,
double.
madam, but it's
Ah.
okay.
It
Yeah.
is raining now very much.
Yeah.
It is correct that we have reduced the demand from, say, NHS 3 to 5. It has come to almost, say, 9.5%. But still there is a huge area. And the main area of concern is adolescent and young women, which you have mentioned very correct. And I think the adolescent program Government of India is having the adolescent health program, which is looking after the adolescent contraception, youth, etc. Also, there is a lot of social disparity, which you have mentioned. Rural urban divide, involvement of the male partners. I think that is going on since after family welfare since almost 35 years. So male involvement is still lacking, which is of utmost important. Also, women with the low socio-economic status, like low education, low wealth, and marginalized community, we have to look after. So, and also very important is regional disparities. Regional disparities is so important that, you know, there are certain areas of rural area where there is a higher unmet need, or, you know, the urban area where services are more available. So all these things, I think, with the consistent efforts of government, consistent effort of the FOXY, Family Welfare Committee, all the organizations, private practitioner, when we could reduce from 23% to the 9%, I am 100% sure with this all the efforts, we are going to bridge the gap, which you tried to show very importantly. So with this, I think, thank you very much for that wonderful lecture. I thank my co-chairperson, Hira.
Madam, please, Madam, please introduce the next speaker. Either you or Dr. Konar can do the honors.
I
Yeah.
can introduce, no problem. Tell me.
Yes, madam.
Please give the
Yeah.
biodata. Huh? So our next speaker is Dr. Sunita Singhal, and she is the country lead of the clinical services and training of the family welfare of the Japaigo. And I must say, I was very, very close to the Japaigo because I was a deputy director of family welfare, and we were doing lots of program in UP, MP through Japaigo. So long connection with the Japaigo, Sunita. Then she's a gynec and obstetrician, previously served in Safdarjung Hospital in Delhi. And as far as the professional experience is concerned, she's a technical expert, leader for the sexual and reproductive health programs, member of National Task Force of Family Planning, National Master Trainer for Capacity Building, and core group of developing the national guidelines for the RMC, and advisor for the healthcare waste management courses, and special for the special interest in the public health focusing and quality care. And Sunita, welcome. And this all the
Thank you, ma'am.
biodata is so close to my heart because all these words we use for our program, reproductive health and child health as RCH, you know, deputy director.
Thank you.
Welcome,
Thank you,
and
ma'am.
please deliver your lecture.
Thank you, ma'am. Thank you for those kind words. And I'm glad to hear that you've been associated with Japaigo, and I will mention it to my team when I go back. So I just please confirm if my screen is visible.
Yes, ma'am. You have to make it full, na? Full
Yeah, I will.
Yeah,
I will. I will.
Yeah,
I will.
it is very
So
much visible.
Thank
Yeah.
you. Thank you, Shobha. So thank
Yeah.
you very much. And I was so glad to see Dr. Ratanmala is speaking before me because two of us have been so closely working with the newer contraceptives over the last almost about 3 to 4 years. Okay, so coming to my topic, and the topic as it says expanding basket of contraceptive choices in public health, particularly Antara program and implants. So I must remind all the team members, the postgraduates who are watching the certificate program virtually. So India was the first country in the world which launched the family planning, and that was in 1952. You all know earlier the focus was population control, but of course the strategy changed, and from 90s the targets are not there. We call it a cafeteria approach, and we call it choices, and choices. Now today it is called, the program is meant to offer women choices and quality of services, improving maternal and neonatal morbidity, mortality, etc. And now government is even saying give quality of life to the woman. So that's how the theme has evolved over the last 50, 60 years. Now coming to the contraceptives, so India also, the government of India has a great journey for improving the contraceptive basket, as we call it today. In the 50s, in the first decade, we just had, OCPs, male condoms, and the permanent methods. Then came in the loop, Lippi's loop. It was there till almost early 70s, when in 80 and all, IUCD, copper IUCD came. That was the IUCD 200B, which was introduced. In 1992, some of the people were trained for the NSV from another country, but unfortunately, as Mandakini said a short while ago, male contraception has not picked up despite this NSV being a wonderful procedure. In 2002, after great studies, 200B IUCD was replaced with IUCD 380A, which lasts for 10 years. 2003, EC pill was introduced. 2012, government added IUCD 375 because that was very popular in the private sector, outside the government facilities. So government added that. Now, after 2012, government has added the injectables, that is MPA, under the Antara program. So we call it here MPA, not TMPA, because that word coincides with another private enterprise. So that is why it is called injectable MP in the government programs, and the program is called Antara. And of course, the indigenous, very, very famous Centroman, Saheli, which was there already. So government brought it into the government's basket. And let me share here that now it is being taken up globally. There are so many queries. Many countries are very much interested, and WHO is working on it. And in 2023, much awaited, the subdermal single rod contraceptive implant was introduced. It came in so late, I think some of us, the senior people sitting here would know there was a big issue regarding introduction of injectable MPA in the country. Because of that, the progesterone-only injectables were not brought into the public health. So once that was cleared up and injection MPA was introduced in 2016, so now it was time to bring in the other progestational agent, that is the implant. Along with that, a subcutaneous variety of the same was also added. So 2 more contraceptives added. Now, what is the advantage of adding the new contraceptives to the basket? It increases the 4 to 8 percentage points in the overall uptake of the methods. The method improves even the continuation rates, and the broader, the more choices you give to the women, it gives her choices what to choose, take up a method of her choice, and she has a right to choose, she has a right to adopt, she has a right to refuse, nahi lena to nahi lena, right? So these are the advantages of adding the contraceptive methods. Now here, since it's about the public health programs, I don't know how many of you have heard about FP 2020. So this was a program, government's commitment, global commitment, following the 2012 London Summit on Family Planning. India committed to achieve few things, and everything was achieved. And now 2020 transitioned into 2030. And under this 2030, again, one of the commitments is, as you see in the yellow here, expansion of contraceptive services for improving maternal and child health, and the extended Mission Parivar Vikas program. Now, to those of you who are not aware of MPV, so under MPV, what government did, that, as Dr. Ratanmala also said short while ago, India is a very, very diverse country. You see, some pockets have a very good, every rate, whatever indicator you want to talk about, but some are very poor. So the government picked up those pockets which were really, had poor indicators compared to FP, and there were about 146 such districts across the country, and a special focus, special budget, etc. was given to them. So that is to reach out to those who really need it. Now, so this is just a background of how the government, targets or focuses its own priorities, strategies, and interventions. If you look at this slide, we have so many already now. 10 methods, as you can see, are here. That includes, of course, the pregnancy kit, which is again in the basket of the ASHAs, the community health workers. So home testing woman, for any woman anywhere, it is possible she gets a pregnancy test done through this FLW. Now, these are the 9 methods, and I have not included the permanent methods here. So if you add those, it comes to 11 methods. Now I will come back to what Dr. Shobha wanted me to, focus a little more about on the implants and the subcutaneous MPA. So implants have been in use worldwide for more than 3 decades. In fact, they are very, very popular in the African countries as well as in the Asian countries. So let me talk about the percentages in Asian countries. So Nepal, 4.5%, Indonesia 4.2%, Bangladesh 1.2, 1.6, Thailand and Philippines more than 1% each. So implants contribute 2.6% of the use of overall methods. Now coming to the subcutaneous, this is a relatively newer methodology of delivering the medroxyprogesterone acetate. So one intramuscular we all know. So this is another self-injection type of a device which women can just purchase and inject it in the privacy of her home. So this has been adopted in the public health facilities, but it is still given by the healthcare workers. That is either the doctors or the nurses or the ANMs who have been trained, who are authorized to do so. Now, what about the prevalence of usage of this variety? So currently 52 countries have got this method in their armamentarium. So this is about the global use. Let me talk a little more about the implants, which I said that it's already there for more than 3 decades. And globally, as you can see here, so this is the long-acting methods. As if you can see the implants, 2.6% here amongst the LARC methods. This is the global chart from UNFPA. Okay, and now with that, after looking at the global data, the government saw that there is a good acceptance and continuities in Asian, South American, and African countries. Good review by Cochrane. Multicentric clinical studies in 2005 and 2009 have proven that it's a safe and effective method. And with a rapid return of fertility, if you compare it with the injectable, where there is a long the woman has to wait for 7 to 10 months for the fertility to return. Here it is, the return to fertility is prompt. So that gives it an edge over the other PYs. Now it's very, very effective, 99.9% effective. WHO recommends it. It is put up in their life-saving emergency drug kit. ACOG has recommended it. FOXI has also recommended. On the FOXI website, there is a paper where it has been endorsed as a efficient, reliable LARC method. Now, looking at all these evidences, the government conducted a meeting, and based on the global evidences as well as the ICMR, if you recall, some of you may have been part of the ICMR studies. So the first phase trial was done on Norplant 2, 1993 to 97. The results were quite encouraging, but that was a 6-rod implant. Then from 2002 to 2012, another trial, long drawn trial on single rod implant called Implanon was conducted across many centers in the country. And the results were disseminated, very, very encouraging results. Then after that, the DCGI approved it in 2015, 2018 onwards. It's available in the private sector. But you know how the private sector, the contribution of private sector to the family planning uptake are always, sort of, it's actually challenging. In fact, there are many challenges that the private sector faces. I must say that. So the uptake was not much, but now the government conducted a health technology assessment that it will be a cost-effective method, and it was adopted. I just want to share a few findings of the ICMR. ICMR found the continuation rate 96% at 6 months, and at the end of 3 years, 66%. and 70 to 80% women conceived within 1 year of the removal. The side effects continue to be, remain the same as is for any hormonal method. Menstrual changes, in fact, we don't call them side effects. We call them the effects of the contraceptive, hormonal contraceptive, that it will cause menstrual changes, which is almost less than 20% women face it. Some women may have amenorrhea. That is, in fact, almost 26% women get amenorrhea. Irregular bleeding, 17%, heavy bleeding, 15%. Now, if we say here, so this is a point of importance, that if a good counseling is done prior to offering the commodity, the acceptance of these changes is very, very high. So it is counseling is the key. And these side effects, generally improve within 3 months, and at the end of 3 years, only about 6.4% women suffered from these kind of effects. Now, this is the results from the ICMR, which was very encouraging. So Government of India got it into the government basket. In 2022, the decision was taken, and 2023, it was launched in a limited fashion. When I say limited, I mean the commodity is not yet manufactured in India. It is imported, or for the timing it is being maybe donated by some big donor. Now, so government is started in 10 states. Hello? So women started in 10 states, 2 districts each, taking care of, covering across India, north, south, east, northeast, west, and urban perspective. Delhi was taken. As you can see, these blue marked states are the one where contraceptives have been introduced. So what is a implant? 4 centimeter long, 2 millimeter in diameter rod, comes in a sterile preloaded disposable applicator with needle for a single use. It is to be inserted subdermally on the inner side of the non-dominant upper arm. Active ingredient is etonogestrel, 68 milligrams. It has a core, and then it has a skin. The skin is vinyl acetate copolymer, and the core has the active ingredient, 68 milligrams, along with some inactive ingredients. So what is it? How to use it? So there are certain limitations with it, that a trained, skilled provider only can provide the implant services. Although in Africa and the other Asian countries, the healthcare professionals, nurses, ANMs in the field are doing it, and not doctors. Hardly any doctor is doing this insertion in these countries. But in India, we are careful, and we are started with the medical college and the district hospitals only in phase 1. So once we get a good results, which we are getting at the national level, it will be expanded, and also we are also waiting for more number of commodities to be made available to us. So removal and insertion both have to be done by the trained provider. There's a 2-day training program that government has developed programs, and Dr. Tanmala and myself, both of us are national trainers for that. So what is it that implant has to offer over and above the other contraceptives? So one, I already
Sorry
said.
to interrupt you, ma'am.
Yes.
Ma'am, your time is up actually.
Okay, I'll wind up in 2 minutes. Will that be okay?
Okay, ma'am.
Okay, so the advantages are that breastfeeding women can take it, and it can be given to women who have blood pressure more than 160 over 100. These are the points which are better than which makes it better than choice than the injectables. Now, coming to the MPA, it is the same as the intramuscular variety already available. The subcutaneous variety only is the mode of injection, which is different. And this is the commodity, if you are seeing on the left side and in the red background, only the quantity of the dose is different. That is, it is 104 milligram in the subcutaneous. Intramuscular has 150 milligram per 1 ml. The volume is 0.65 ml in the subcutaneous variety. So this comes in a pre-filled auto-disabled syringe called a Uniject system, which the woman, after learning, can self-inject. So there is no other difference. The difference is in the site of injection. As you can see in the upper chart, it is the intramuscular regions, the three sides, deltoid, gluteal, and the outer side of the thigh, whereas the subcutaneous variety goes in the abdomen. It can be in the upper outer part of the thigh and the upper outer arm. So these are the sites of injection. There is no difference in the action, no difference in how it is to be taken, how it is to be repeated. No difference at all has been studied. So it's just the convenience of the that woman can take it herself, which in the private sector, of course, women can take it up. Thank you, and my apologies for overshooting my time. Thank you.
Thank you, Sunita. Thank you, Sunita, for that wonderful lecture. And we are always looking forward for the modern technologies, and women are also very much wanting to experiment with the modern technology. And I think Anahita will agree that we are having this implant training on a major scale. And so many companies are now, a group of gynecologists, TOTs are being conducted all over, India, especially the companies which are taking place, and TOTs are happening. So after the copper teas, which was in the government for a long time, that was very favorite of the government, that contraception program. Now the implants is going to take place. And in the implants, there are varieties, modern gel-like implants, male implants, so many things will be. With the AI also, there are many technologies which are improving. So I think this is a wonderful lecture, and I hope that all the, participants are very much, benefited by this lecture. So with this, thank you very much.
Thank you, ma'am.
Yeah.
Thank you, ma'am, for this excellent scientific lecture. And thank you, Mandakini ma'am and Kunal sir, for chairing this session. We are very much obliged. Moving towards the next part, that is symposium, creating basket of choice for vulnerable populations. The rapporteur is Dr. Shobha Gudi madam. Madam is professor and HOD at St. Philomena's Hospital, chairperson, Family Welfare Committee, FOXY, 2019 to 22. Was president of the
Can we avoid this, and can I please take over from here and introduce the?
Yeah, sure, ma'am, sure.
Thank you, Rachna. Thank you.
Thank you.
And I have been actively posting in the chat box that I have Dr. Rachna Jaju. I really thank her a lot for working with me shoulder to shoulder on this project. And our effort has been to make this subject highly interesting, practical, and we hope to give a lot of take-home messages. So can you share the CVs of my faculty, please? Very quickly, I would like to welcome on board Dr. Anupama Rao, very dear friend, senior technical advisor from Japaigo, has done a lot of work in this field, and right now she is working for maternal health. But I roped her in, saying that she has done a lot of work in young married couples when she was with PATH Foundation, and so she is here with us today. Welcome, Anupama. Next, we have our own, please. Next, please. Yes, and who doesn't know Dr. Anahita Chauhan, the former professor and unit head, State GS Medical College, of course, and she is also the past president of MOGS. And of course, right now she's assistant editor of Jogi, and we look forward to her brilliant career, which she will have as Jogi editor in future. Welcome, Anahita. Next, please. Yes, and we are very proud today. We have two people from defense, Colonel Sanjay Kumar Sharma, Professor of OB-GYN, AFMC Pune. Welcome, Dr. Sanjay.
Thank you, ma'am.
Yeah, and Air Commander Sanjay Sharma from Delhi. Of particular note is his work with the third gender populations. He has been the co-chair WPATH International Diversification and Member Outreach Committee also. And please pardon me for not being able to go through the whole list. both of you, Dr. Sharma's, and of course, Mrinalini, who has worked with me again hand in hand for the Sankalp project, which I used to have as chairperson Family Welfare Committee. She is from Delhi, and she is a fellow. Of course, she is FICOG, founder president of Delhi Gynec Forum Southwest, and a very active member of AOGT. Next, please.
Thank you, madam, for including.
Yeah,
me.
and Rekha Gurumurthy, a senior professor and vice principal of Sri Devi Medical College, Tumkur, again one of our Sankalp champs. Thank you, Rekha, for being here. Next, please. I think that's done. So let me just say, can you stop sharing? Yeah, I will just very briefly talk a few lines. Of course, I'm not going to take away anybody's time. I will just because somebody has been asking about what is unmet need, though I have put it up in the chat box, I thought that I will just bring home the point that today we have to deal with vulnerable populations in everyday practice, and that is what this symposium is about. And we need to think about equity in contraceptive use, irrespective of their socioeconomic status or their gender, in fact. And this has been spoken of. Unmet need has been defined already. So I just wanted to put here this kind of equation, which is telling you here that women of reproductive age, for example, if you want to find out the unmet need in reproductive age group women, then the numerator is those women in this age group who are married or in a relationship and do not have access or knowledge or affordability for a method of contraception. So they form the unmet need for family planning in the numerator, and below should be the total number of women of reproductive age, the same age group, right, who are in a marriage or in a union or in a relationship. And you have to create a percentage by multiplying this ratio with 100, and that gives you the percentage. So I have also typed in the chat box that you can determine this kind of unmet need for your own institution, for your own hospital, for every age group. You can do that for adolescent, you can do that for your delivering women or post-abortal women, and then we can strive to improvise, reduce this percentage. That is all I wanted to say. And with that, I invite, because this is about TFR and contraceptive usage rate, I just wanted to show you this blue here. And I think we are happy that the TFR, the total fertility rate, is actually falling. And this is an old slide. Today, the TFR is falling to, rightly to 2 in many of the states, right? Many of the states. But what we must look for, and why we are having this session, is to improve this blue. And this blue is at 60, and maybe it is 65 or short of 70. It should really cross 70 and go towards 80. And that is when the unmet need will come down. So with that, I will stop share, and I will invite Dr. I think the first speaker is Anupama. Yes, please share. Yes.
I'll just share
Anupama.
my screen.
Yeah, please share.
I'll
Yeah.
just do that. Yeah. First of all, huge thanks to Dr. Shobha, ICOG, everyone, all the dignitaries present for giving me this opportunity. And is my slide deck visible?
Yeah, everything is fine. Please go ahead.
Okay,
Yes.
okay. All right, all right. So over the next 5 minutes, it's a tall ask actually to talk about, the contraceptive choices for young married couples. So I have basically structured it into why there is a need for this issue and what really are the gaps and how we can, go about solving this. So what is the need? And why there is a need for contraception for young married couples is India, as we know, is going through a huge demographic dividend shift, and we have almost 30% of our population being in the age group of 15 to 29, which is classically defined as young population, youth population, which is counting to about 420 million. And out of these, about 1/4, as per NFHS 5 data, about 1/4 of the women are married off before the age of 18. So there you can see one actually should not be married because she's already appearing there in that figure. And also 1 out of every 4. And the second thing is that if they childbearing before the age of 19 or at 19, and the rest who don't want to continue because of lack of access to contraception or lack of awareness about contraception, they land up with unintended pregnancies, which is, you know, as per the study, in pregnancy,
Anupama,
Yes,
your voice is little bit
pregnancy with
breaking
about
up.
15.6 million abortions occurring in India. So the population being young, lack of access and awareness, huge, you know, ask why we need to concentrate and is it better now? Is it better now? Am I audible?
Yeah, you are. Go
Yes,
ahead.
yes.
Yes.
Okay. Okay. So coming to the contraceptive prevalence and unmet need, already, they have spoken about it, but I want to draw your attention to it. What we found in the field is most of the women, you know, because of family pressures, because of various social and gender norms, are forced to finish their childbearing early, and actually the brunt of the contraception is borne by women, and most often it is the permanent method after they finish their childbearing. So there is no option for
Anupama,
them
I think
not to delay
You
and
put your
Yeah.
not
video
to
up.
space. So this is what we found in
Anupama,
most of our projects in
Anupama, can
the
I
Yes, it is
states
okay.
can I
that we
interrupt
worked on,
you?
female sterilization, with
I
very
don't
little
think she can.
contribution.
Hmm.
I can place in,
Yeah, thank you. Yeah.
okay, I can put off my video.
Yeah, we
Yeah, can you
understand.
hear
We
me now
understand.
better?
Yeah. Yeah.
Is it better?
It's
Okay. Actually, I'm in a remote for this.
yeah.
So as
No
madam had
problem. No
already
problem. Yeah.
as madam has already told, the unmet need is 9.4%. But you can see in the age group that we want to worry about, 20 to 24, it's very high, almost 17.3%. So this is what is the need and why we need to focus on this and shift from the limiting methods to the spacing method for this population. So what can be done for that? What are the gaps that we need to this thing? So we usually follow the seed model in most of the projects that we worked in. So all of the 3 arms of the seed model needs to be strengthened. So we have a demand side problem where the woman is not at all aware. As you can see, only 20% of female non-users are being talked to, and that too by frontline workers like ASHAs and ANMs. So they are not even aware that something like this is available. Secondly, there is lack of access to them because health workforce shortages are there, lack of skills of the providers, provider bias, and stockouts. And the third thing is enabling environment is missing because a lot of social and gender norms are there which are preventing them from using contraception, especially things like what we found most often is pressure to bear a child, prove fertility, have a male child, or lack of decision making from the women, lack of autonomy and agency by the woman. So these are all the social and cultural norms around which we need to work with these young couples. So we need to increase the woman's autonomy and agency. So what are the options? How can we do it? So most of them, at least the important ones were already discussed earlier, especially the newer ones like the implant. So we have a huge list of basket of choice, and they're keeping on increasing because we know that with every increase in the contraceptive choice, about 8 to 10% of the contraception uptake goes up. So every time the government increases the basket of choice by 1, about 8% is expected to increase as far as the modern contraceptive prevalence rate, MCPR, is concerned. So we have all the spacing methods. We know so far that condom is only 9.6% used by the males. So male participation is very important. in the public sector, we still have the higher dose ones. We need to bring in the low dose ones. Then the emergency contraceptive pills is most often used as and it should be used as an emergency. Sencloman, because of lack of compliance, is getting problems and it's not being used. Progesterone only pills has problems in availability in the public sector. Antra was very popular. Government pushed it, as Madam Sunita told. But the only problem is providers are not aware of the side effects. So there's a bias, and the providers themselves, especially in the public sector, they try to, not address those issues and not counsel the women properly. And then therefore there's a dropout in the second and third dose of the DMPA injection. IUCDs, again, there's a bias towards IUCDs more in the public sector. Implants, there's a huge push, and thanks to Jhpigo's work by Dr. Sunita, it's been introduced, and I'm hoping that it will be taken up. LNG IUS and the new contraceptives, of course, they are not available in the public sector, but in the private sector, hopefully with the introduction of this, already LNG IUS is very popular. So these are the things that need to be offered to the young married couples. And of course, postpartum and post-abortion contraceptive options are always there, especially popular being PPIUCD, and glimpse of what needs to be done and how it needs to be done and why it needs to be done as far as young married. So we know, I want this picture of Bihar. Bihar was one of the states that we worked in, and earlier Madam also spoke about it being an MPB state. So this actually is a picture of two girls in the COVID era. But again, I'm hoping that with the shift, these girls will have very good protection as far as contraception is concerned, and they will be having a choice of when and how many children to have. And with that, we all know. Thank you, Shobha. Thank you again for the opportunity.
Thank you very much, Anupama. Thanks a lot. And we appreciate that in spite of being in a remote place, you joined. So next I invite Dr. Anahita to share her screen and start her talk on unmarried. This is a very vulnerable population. We are all having these clients coming in today. So go ahead, please. Yeah.
Thank you, Shobha, and thank you to the organizers and the ICOG and Foxy team. I think I have sent my slides, so if they could be played, and I'm going to be extremely brief. And luckily for me, Dr. Ratnamala and Dr. from Jhpigo have already laid the groundwork for what I wanted to speak about. If somebody could share my slides.
Post?
Yes.
Hello?
Yes, ma'am.
Can you
play? Can you share?
Ma'am, इनका slide मेरे पास नहीं है.
अच्छा, ठीक है.
Yes.
Nilima is there?
It's all right, Shobha. I have only.
Can I share the slides? I have them.
Yeah, please.
Yeah, please share. Please. Yeah.
I have only 2 slides.
Yes. But I want them to be seen. Yeah.
I am not going to really focus on TFR and all the technical aspects.
No, we don't need numbers. We need now the.
Yeah. So I'm just going to start by talking about the unmarried client who comes to us, who is sexually active. The first mistake, I think, is that we allow our bias to come into the picture and don't ask these clients, are you sexually active? Would you need contraception? So first of all, to all of you, make sure that you are giving enough time to the unmarried client to talk about her sexual and reproductive needs. Unfortunately, this is opened on WhatsApp, but basically pregnancies in the unmarried group are mainly because they don't know what contraceptives to use, or they don't have access to contraceptives. And this is really sad because there is a basket that is available for our patients, and we should be promoting the safer options rather than allowing patients to just use the condom if and when they have an opportunity to use one. So what are their concerns? If we talk to them about contraception, their concerns are obviously they want something which is very, very, very effective. So they want effective protection. And when we explain to them that the condom does not have a very high percentage to protect you, it may be good to prevent STIs and other infections, but for prevention of pregnancy, condom doesn't do a very good job, then they may be more receptive to thinking about other permanent or long-acting methods. Second thing that they want is confidentiality in their choices. And I find that a good option when we are prescribing the oral contraceptive for these unmarried women is to explain, especially if they are accompanied by older people from the family or their mothers, to explain that, you know, because of her irregular cycles, the oral contraceptive is going to help her. That's a very easy way to get over all the judgment that can follow if she is on oral contraceptives. Of course, the practice I'm in now in Mumbai is a more boutique kind of practice, I would say, but I have worked for many, many years in the public sector also. And I feel that it is us who put a lot of blame or a lot of guilt on younger unmarried people who are sexually active. So that's number one. We have to get rid of that. And we have to be open to hearing them out and understanding their needs. The next thing that they want is they want no side effects. Now, obviously, we know that we have so many contraceptives because none of them is perfect. And if we can explain to them that more or less the ones that we would recommend for them have least side effects and maximum protection, then they will follow these methods. And they also want that there should be some positive health benefits. I have patients who have been on low-dose oral contraceptive for years together, and they actually come and ask me, do you want me to stop this? Because I'm so happy, I don't want to stop. And again, here is where we should come in to say, you don't need to stop. You don't need to take a break every 2 years or every 4 years or every 5 years. You can continue to take low-dose oral contraceptives safely. So that brings me to the ideal contraception for a young or an unmarried person. This should be a safe, effective, and easily reversible contraceptive. And if I had to categorize the best options, of course, combined oral contraceptives would be high on the list, but I would also look at long-acting reversible contraception. And in the long-acting reversible contraceptives, I would definitely opt for either an LNG IUS or an implant. Can I just have you move the slide a bit so that we can look at the next slide? Okay, so basically what I've done is I've just kept the best options for the patients. And here again, I would like to say that there are more and more educated women.
Anahita,
Yes.
give me 2 or 3 seconds. I will share for you. Rachna, can you please stop sharing?
Yeah.
Sorry about this. Yes, please stop. I will share for you. I'm sorry.
Thank you. But I can still talk.
Yeah,
So,
go ahead. Go ahead.
So the LNG IUS, unfortunately, when it came to India, we all thought it was too expensive. We all thought, how can we spend 9 or 10,000 on a contraceptive option? And so we kind of reserved it for the 40 plus, for the ones who had menstrual irregularities, for the non-contraceptive benefits. But let's not forget that LNG IUS is an extremely effective and recommended contraceptive, especially for younger women. it has been shown in the WHO eligibility criteria to be category 1 or category 2, even in younger adolescent girls. Of course, we are not talking about the adolescents as such today, because we don't want to get into the POXO, but we can safely use LNG-IUS even in 15 and 16-year-old women who are sexually active. Having said that, there is a newer low-dose LNG-IUS, which is called Skyla. Unfortunately, it's not available in India, but it is in use in the West. And Skyla has an easier insertion because it's slimmer, and it has less dose of levonorgestrel. Unlike LNG-IUS, which is 52 milligrams, the Skyla has, I think, only 14 milligrams, and it has to be used only for 3 years. The advantage of a lower dose LNG-IUS is that they get regular cycles, and with the regular cycles, they don't have so much of, fear every time that they don't get their periods. Keep in mind that the only side effect, thank you so much, Shobha, and now this is very clear for everyone to read. The other advantage of the LNG-IUS as opposed to a copper IUD is that there is no increased risk of PID, there's no increased risk of infertility. The only 2 drawbacks, I would say, is that yes, you do need to schedule the insertion with either sedation or maybe misoprost to dilate the cervical os, because there will be pain in the unmarried girl who you're inserting the LNG-IUS in. And sometimes it has been found that the side effect which is seen somehow more in younger women is depression. So keep that in mind when you are thinking about the LNG-IUS. Otherwise, it is an excellent, excellent option for younger women. Also, with more and more women having endometriosis, having fibroids, or so many other problems, the LNG-IUS does become an excellent option. Now let me talk about Implanon Next or Implanon NXT. And this is something that I have been passionate about. And I think looking at Family Planning Association of India, who has gone streets ahead of everyone else with their Implanon program, it's really encouraging, because if the Implanon is inserted, the only thing that we need to do as providers is counsel the patients. If we counsel the patients well, they will all accept the Implanon NXT. And here's the thing, we have 3 distinct advantages of the Implanon NXT over even LNG-IUS. Number 1, it is extremely effective, 99.95% effective. It's an easy OPD procedure for insertion and removal. And here I feel that the company who has launched this has made a bit of a mistake by asking that only doctors should insert, only those who are trained should insert. If we can do laparoscopic surgery, or if we can do any other surgery, this is such an easy procedure. It's literally see one, do one, teach one. The next important advantage of the LNG is that it does not interfere with routine activity. It cannot be seen, it can hardly be felt. And the return to fertility, unlike other LARCs, is very, very quick, and in fact 17 to 18 days. So in case the patient is concerned that she wants to get pregnant even after 3 months or 4 months, you just have to remove the implant and she will resume her fertility within the month. There are some side effects like headache and breast changes, but this is typical of all progesterone devices. So this is the only thing that the patient needs to be counseled about. But unlike the LNG or the DMPA, there is no complete block of the menstrual cycle. There is only a complete cessation of periods in about 50% of patients, and in about 25 to 35% of patients, they will get regular scanty periods also. So this becomes a wonderful, wonderful option for an unmarried girl or an unmarried client, I should say. Of course, the other things like copper IUD are also there, but the copper IUD does cause a lot of heavy bleeding. And in case the client is going to have multiple sexual partners, it may not be the best advice.
Thank you.
I'm going to end here. Thank you so
so
much. Thank you.
Thank you so much. And I think the very the astute audience, they are understanding by now that we need to give them a basket of choice and they have to select. But yes, highlighting the methods as you have done, that was wonderfully done, Anahita. Thank you so much, and I'm very happy that you are amongst the faculty today. I would now request Colonel Sharma, Dr. Sanjay Sharma, to speak about his subject, and that is contraception in adolescent. Is that what you're going to speak? Yeah.
Good afternoon, everyone.
Yes.
Am I audible, madam?
Yes, you are audible. Yes.
Yeah. Can slide be shared from your end?
Okay, I'll just try. I will
group.
try. I think I have downloaded it. I will just open. You keep on talking. I will open that slide.
I bring greetings from the FMC, and thank you so much, Dr. Parag Beniwale sir, Dr. Shobha madam, and organizer of this event for giving me this opportunity to be here on this platform and say a few words about contraception in adolescence. Madam gave me the task that I have to cover this topic by case scenarios, and 5-minute time was allotted to me, so I will try to be brief.
Yeah, so that we can have a good dialogue at the end of it, and audience also can ask something.
Yeah,
that's the whole point. Yeah,
ma'am. Absolutely.
I'm just
choices of contraception in all the age group, that include the adolescent also, is concerned. My previous speaker has given all the choices, and they were absolutely right and convinced in conveying that all the options can be offered to the adolescent age group too. So the unintended pregnancy in every age group, that include the adolescent also, is a major public health challenge. And if you see the statistics, more than 16 million birth worldwide takes place in that adolescent age group. And 3 million girls of the age group of 15 to 19 years, they undergo unsafe abortion every year, which not only increase the morbidity, but at time mortality also. If it is not only the matter of pregnancy, it is the STIs also, which also poses a significant challenge. The reason is because all STIs are not in the clinical scenario. We see only tip of iceberg. If we see only HIV, more than 50,000 male in India are HIV positive in the adolescent age group, less than 19 years, and more than 46,000 females are HIV positive as far as the age group less than 19 years is concerned. So what are the barriers as far as use of contraception in adolescent age group is concerned? That in most of the time it is an unplanned event. If we see the coital activity, it is not a plan. So the lady is not prepared, and at time they are not able to use any contraception. So many times we see that there is a lack of awareness as far as the contraceptive methods are concerned. And so many misconceptions are there about various choices. And even if they are aware and misconception are there, at time they are reluctant to use any method of contraception. in a country like India, there is limited access to the healthcare facility also. And in this age group, they are very reluctant to acknowledge the sexual activity. Next slide, please. So I will try to cover this contraception and adolescent age group by two case scenarios, which are real time and which I have seen in my clinical practice. And it is not very old, it is quite recent, that a 19-year-old unmarried college going girl with normal BMI visited OPD, and she gave history of irregular cycle, and she says that period comes only once in 3 to 4 months, which basically she was trying to hide. So as obstetrician, we have been told that you have to categorize all the women in two major category, that is married and unmarried. And in both group, there are two subgroup, whether they are pregnant or not pregnant. So I put the probe on bedside ultrasound, and to my surprise, it was 14-week viable pregnancy she was carrying. When she was told that this is the scenario, so then she accepted that yes, she had intercourse, and that may be the result of this. So what are the lessons we have learned, or what are the lacunae which we see in this particular case scenario, that there was a lack of sex education. Had she been educated earlier about this, maybe she would not have landed up in this kind of situation. And again, use of contraception, which has been emphasized earlier also, and I would also say, had she been aware about the use of contraception, she would not have faced this kind of situation. And the another thing is that she did not timely report to the healthcare facility. Maybe once she had missed the period, had she reported at that time, OPD basis medical termination of pregnancy could have been easily offered, and she could have got away with the pregnancy. So as a healthcare provider, where do we stand? That we have to see every patient with non-judgmental, and we have to be open, and confidentiality of the patient has to be maintained. And as healthcare provider, we must offer the kind of services, whatever best we can do for that particular individual. And if we see, the counseling is very important right from the beginning, when we are offering them the contraception, and when they are consistently using the contraception, and subsequently if they land up with pregnancy, and when we are terminating that particular pregnancy. So counseling plays very, very important role at all the levels. So if we see the second case, this is again real time, which I faced, that I came across when I was serving as gynecologist in UN peacekeeping mission, that a well-educated lady who was working as head of the HIV/AIDS unit in UN mission, where I was there, she, during her adolescence, she had only one coital activity, and she got HIV infection from her partner. And later on, when it was discovered based on her symptom and presentation that she is HIV positive, after that she decided that she will not get married, and she devoted her life to basically look after the people, those who are living with HIV. And she was head of that unit, and I happened to interact with her because I also did a HIV counselor course, and then I came across to know about her story in detail. So again, here maybe she was well educated. Conventional education was not a problem, but yes, sex education was definitely a problem. Had she been aware about this, maybe she would not have landed up in this type of scenario. The another thing, the earlier, like one speaker has emphasized, that barrier may not be a very good choice as far as pregnancy is concerned, but adolescent age group, because of their high risk behavior, we must understand that it is not only the pregnancy, it is these STIs also. So in this particular category, along with the methods which are used to prevent pregnancies, the over and above that, the barrier method must be advised to them, and they must comply, for the simple reason to take care of the sexually transmitted infections. So what next slide, please. So if we see that what are the choices as far as adolescent age group is concerned, we have already seen and learned through the previous speaker that all methods, whatever are available, can be prescribed to the adolescent age group also, unless there are certain medical or contraindications based on the WHO eligibility criteria. So all methods can be offered to them, including the IUCDs, and my previous speaker, madam, has spoken about details regarding Mirena and Skyla, and very well covered by Madam. And counseling is the most effective intervention, which we have to like emphasize right from the individual is visiting you in OPD, and it has to be re-emphasized again and again and again. That is how she will be compliant as far as the methods of contraception are concerned. Role of dual protection, along with the methods which are being used to prevent the pregnancy. Along with that, barriers should also be advised to them, especially for those who are indulged in high-risk behavior and having multiple sexual partner, because you cannot predict when they will get the so many STIs. ABC strategy as far as contraception is concerned is A stand for abstinence, that ideally they should remain abstinent, which is easier said than done. Regarding abstinence in adolescent, it should be emphasized that they should start their sexual life. They should delay it as late as possible. And B is be faithful. They should be in monogamous relationship and they should be faithful to each other. That is B basically stand for being faithful, and C stand for contraception. If they are sexually active, if they are not abstinent, then they must stick and use some or the other method of contraception. And emergency contraception should be offered wherever it is required, and it should not be used as a routine method of contraception. And I would like to end my talk with that what I have been taught by my teachers, that one should never refuse the MTP to any patient irrespective of her status. So till date I follow that, and I have never refused MTP for any patient who is visiting to me in my OPD. And counseling after you have done your job as MTP is must, and contraception has to be part of your termination of pregnancy, and it should be prescribed to all the patients whom you are treating. Thank you so much.
That was a lovely presentation. Thank you so much, Dr. Sanjay Sharma. Now I request Air Commander Dr. Sanjay Sharma to share. I do not have your slides, and I think this will be the first time that contraception for the gender diverse will be spoken. So I am rather proud of this choice of ours, and we welcome you to share. Yes.
Thank you, ma'am. And it's really an honor and a privilege to be here among so many gynecologists. I am going to be very honest and declare right at the outset that I am not a gynecologist. But my talk is going to be addressed to mainly the youngsters, because I am going to be talking about a subject which is new. It is only 40 years old. And I'm also going to be asking these very simple questions, because it is from these questions that my topic will emerge. I want you to take a second and think that how do we view pregnancy and how do we view contraception? Is it choice, or are we looking at chances? Are we debating wanted versus unwanted? Where do we place contraception? Is it a part of sexual health, or is it a topic to be considered when we talk about reproductive health? Or is it a bridge which is essential both for sexual well-being as well as for reproductive well-being? Mind you, the catchword is well-being. Most importantly, how you as care providers view diversity. And when I say the word diversity, I want you to think, how do you as care providers look at different human forms? Not just the two that we grew up learning about, the male and the female, but that entire spectrum of human form. Because diversity is a norm of nature. It is the rule. Your view as to how you view diversity Is it a pathology in your mind? Or are you viewing this as a normal variation of nature? Are you looking at the 3 SDs and the 4 SDs and the 5 SDs of the normal curve of human form? As you debate on those questions, I want to talk about why the president of FOGSI thought that it is so important that we discuss contraceptive care for the gender diverse people. The barriers for contraception in this group, the LGBTQAI group, comes from 3 sources: the care provider, the care seeker, and yes, the method that we are going to use. The care provider, that is you. What are your personal prejudices? Do you carry opinions? Or are you going to deliver contraception based on scientific evidence? Do you have the scientific evidence? Do you have the standards of care that are to be used when dealing with this subgroup of normal people? And we have 2 such standards which are available in the world. One is the World Professional Association for Transgender Health Standards of Care version 8, which was put out in September 2022. It's worth Googling and looking at. We also have Indian Standards of Care, which the Association for Transgender Health put together, and you'll be glad to know that this standard was put out in 2020, and now that we have the WPATH SOC 8, we are going to be revising it, and very soon, by the end of this year, you're going to have the ISOC 2, that is the Indian Standards of Care. There was a mention of POSCO. And there is this doubt in the mind of care providers that, am I legally right to provide contraceptive advice which may be life-saving for a group of people? Is this something that is unethical? Well, let me clear the air. POSCO is for prevention of offenses against children. You as care providers are not doing any offense by giving them life-saving care. And this is something which we all need to realign. We all need to remember. POSCO is out of the domain of provision of healthcare in an ethical manner, in a facility that is well equipped. Yes, we need changes in the medical curriculum because we are now looking at a subset of people who we did not study about when we were in medical colleges. We need research. In our country, unfortunately, we have figures which say male and female. We do not talk about the gender diverse or the people who stand under the umbrella of transgender. We are not trained to give trauma-informed care. And this segment faces trauma. Macro trauma, which is given by society. Macro trauma, which is given by people who do not understand them. We also need to understand in detail what is informed consent. Because when I am talking to an individual who is belonging to the minority, am I giving them advice which I think is correct? Or am I going to be standing in their shoes and providing them what they desire? Am I going to do participatory care? Am I going to learn from the lived experience? And am I going to be ready to manage the undesirable outcomes of the interventions that I do? Yes, like it was pointed out, that no contraceptive method is 100% complete or free from side effects. But if there is an undesirable outcome, am I going to handhold, counsel, and be ready to make provisions so that there is well-being? Do I know the care seeker? Do I know the person from the LGBTQAI community? Do I know that they suffer from what is known as minority stress? A stress that comes from being in minority. Just the fact that you are less in number, you are less represented, that itself becomes a stress factor. And then comes the intersectionality of what is your religion, what is the economic status, and multiple other intersectionalities. Do we know that this person is hypervigilant, very anxious? They are questioning. And this questioning is often constituted to be argumentative behavior by people who are transgender and gender diverse. We forget that we have given them no reason to trust us. And when they question, we need to inform. We need to approach them not with curiosity, but with genuine concern. And we need to understand that these people take cross hormones. The person who is standing in your OPD with a beard and was assigned female at birth is a person who puts medical transition before contraception. This is the person who when we offer contraception, need to select that is the method that I am selecting going to interfere with the medical transition which the person is seeking. Am I going to offer a method which is going to help them achieve both? Do I have misconceptions about the contraceptive methods? For example, it is a common misconception that most of us carry that if a person is taking testosterone and trans men are doing that, they are not having periods, that in itself is contraception enough. We need to educate ourselves and also educate the care seeker that you need additional help, you need additional support. And lastly, what method are we going to use? Because here we are dealing with people who have poor health-seeking behavior, who are scared to talk to healthcare providers because healthcare providers judge them. They are afraid of getting their bodies examined. And hence, when you as care providers are going to offer all the contraceptive methods, I heard that there are 11, both temporary and permanent, then are we going to sit down, put the basket in front of this diverse individual, explain to them, and then in a participative manner, decide which one is the best, respecting their choices. Respecting their choices, because that is the most important trust building activity which happens from a care provider. I would implore the young people to please download the WPATH Standards of Care version 8. This is a scientific document because this will give you the base on which you can look at human beings and provide the care that they are asking from you. I would end by saying, accept diversity and support well-being. We are going beyond health. We are going towards health plus happiness, and that is well-being. For those of you who are interested in learning more, I have put my website and email address and my number here. I would love to.
You can share this in the chat box.
I will do that.
Yeah.
I will do that, ma'am.
Thank you. Thank you, Dr. Sharma. Thank you. Thank you. That's a nice one. That caption is a nice one. Yeah. Thanks a lot. Yes. So we have next. Yeah. This was something very different that we wanted to listen to, and thank you for bringing that perspective. I will next ask Dr. Mrinalini Mani to speak about post-abortal contraception very, very briefly. I'm sorry, but we are running out of time, so kindly please stick to time, each one. Thank you. Mrinalini, you want me to share? You're muted. You're muted.
I'll share the slides. I'll share.
Yeah,
the
please
slides.
share.
So,
Please share. Please share. Yeah.
so I think this is.
Yeah.
Everyone can see my slides. So
Yes, can see.
Thank you very much at the outset, Dr. Shobha. It was indeed a pleasure to be reconnecting. And topic given to me was post-abortal contraception. So much has been spoken about contraceptions by the last speakers, and my job has been made easy actually. Much has been discussed regarding the choices. So I'll just deal in short regarding how to go about PAFP, that is post-abortal family planning. And as we know, what is the rationale behind having post-abortal contraception? The statistics has been shared already. I will not duplicate. And India, as we know, we have 5.6 million abortions every year, and 3.3 million are in the adolescent age group also. And most of these women, they resume their sexual activity within 2 weeks post-abortal. And as we all know, ovulation can start within a week time. And even abortion, they contribute to a lot significantly to our maternal mortality. And if we provide post-abortal contraception or postpartum contraception and avoid unwanted pregnancies, then 90% of mortality because of unsafe abortions can be averted. WHO also talks about at least 6 months spacing between pregnancies after post-abortion. And most of these women which they come to us, why did they have an abortion in the first place? It was an unintended pregnancy in majority of the cases. So that basically it means they did not want a pregnancy. So we have to handhold them and counsel them properly so that they do not go for contraception again. They choose a contraceptive and do not go for abortions again. And and what happens is when we counsel the patient and they're not counseled enough, they go back without a contraception. And I being in the public sector, I have seen that 90% do not return back for family planning services. So the key to this is post-abortal family planning is counseling, which is the key for any family planning services. And quickly to recap, like I mentioned earlier, she can resume her ovulation within 10 days and post MMA up to 20 days also. And after second trimester, within 4 weeks, fertility returns. So what do we do regarding counseling? So this is a major pillar, and we have to tell them why spacing of 6 months is required, the return to fertility, and also the choice, the baskets which is available to her has to be shown to her. And like my earlier speaker mentioned, मना कर देते हैं residents के अगर contraception नहीं लिया तो फिर MTP नहीं करेंगे, and she goes back, fearing that she will not be offered MTP services, abortion services, because she will be forced to use a contraceptive. And initially it used to be just 2 options for her, IUCD or ligation, a permanent method if she was a multigravida. So here now we have a wonderful basket. We have 11 methods I discussed, and so she can choose from any of the available methods, and she has to decide. It is her choice. She has to make comfortable, and we have to guide her through that to use a contraceptive. And once she chooses the contraception, we can of course do a method-specific counseling and tell her the nuances of what to do in future regarding that. And also ask her, and we should not forget, whatever method she uses, we must always advocate dual protection method. Use of barrier method has to be told to her so as to avoid infections in future. Then once we have counseled the patient, if she chooses a family planning method, good enough, we can initiate it immediately. And if she's not able to decide or she's not eligible for a method, we should always schedule a follow-up. And here in follow-up, I would like to say, in private, most of the patients do come back for follow-up, but in the government sector, they're invariably lost to follow-up. So what our job as faculty sitting in the hospitals, government hospitals, is to tag them to a peripheral worker, ASHA workers in this case, and also ANMs with us. We always note down the telephone numbers so that we can ask them if she misses her appointment, so as to come back that her appointment is due and she needs a follow-up. And once we have seen the eligibility and any method can be given to her, we have to just ensure that there is no complication and adequate pre-abortion counseling is given, or even we can counsel post-abortion also in that case. And we have to see the MEC criteria of whatever method she has opted for. And choices available are in plenty. So I'll just go by trimester wise. After first trimester abortions, almost all methods can be used immediately. If it is a spontaneous or induced method and we have done a suction evacuation or an MVA, we can give her any method if she meets the MEC criteria. Now, what about MMA? If we are giving her MMA, then most of the methods can be started on day 3 when we are giving her misoprostol. And COCs and POPs, they can be also given on day 15 if there are no contraindications and we are reasonably sure that she's not pregnant. And also IUCD and LNG devices, they can be inserted after 15 days once the abortion is complete and no infections are there. We can easily do that. And other methods like now we have implant with us, we can also insert that on day 3. And in our hospital, we are inserting implants in the last 6 months in the second phase rollout in the state of Delhi. And it has a wonderful uptake. And then sterilization, of course, we have to, in first trimester, we can do immediately, but for MMA, we have to do it after the next cycle. In the second trimester, again, all methods can be done immediately. And sterilization concurrently on or within 7 days of mini-lab. Now, if a lady has come, most of the cases we have seen with MMA, these way, or she comes with an incomplete abortion, when can we put in an IUCD or start contraceptives? So if a lady has come within 7 days, then we can start our COC, POPs or Centromin, MPA or implants can be inserted within 7 days without a backup method. If she's coming after 7 days, then we do need a backup method for 7 days. And in case of POP, only for 2 days, the backup method is required. And IUCD, if she's coming within 12 days and there is no complication associated with the abortion, then we can insert within 12 days. And if we are inserting after 12 days, then we need to give a backup method. And we insert only if we are reasonably sure that she's not pregnant. Otherwise, we call her after the next cycle and we send her home, giving her barrier method and an EPIL. So we do not leave her unprotected. That is there. And what we need to understand is that these methods, all of these methods are very safe, and we have to counsel the patients, and we have to ensure that no lady is left without a post-abortal family planning method given. In my institution, we started with 5% rate. Now we are up to 90%. We are giving some method, and 10% who do not agree or want to come later on, we do send them with barrier method and EPILs. And also one has to assure that even in the primary gravida who has unfortunately who lands up in a missed abortion, or we do an MTP because of any reasons, or then we counsel them for regarding 6 months spacing, and for that we prefer a method. She wants a quick reversible, so that what we in practice generally is we give a shot of MPA. She can take 2 shots of MPA or 1 shot of MPA, and then she's safe, because I do not want to give her a longer method. And so the kind of people who come to us, they generally don't want to go in for a oral method of contraception. So in the end, I would like to say this manual by the Government of India, this is very good. We all must go through it. The young residents seeing this webinar, you just go through this manual. It's not very huge, just 30-40 pages manual, but is there all the details, what is required for post-abortal family planning. And we have to ensure that we have, like we talk of respectful maternity care, now we are talking in terms of respectful abortion care in our centers. And as the title of this webinar, pregnancy should be by choice and not by chance. Thank you very much. I hope, Dr. Shobha, I was brief. Yeah. Hello, Dr. Shobha.
Sorry, I was muted. So thanks a lot,
You asked me to be
Mrinalini.
brief, so I was brief. I couldn't
Yes,
delve
yes, the
into
time
great
itself was
details.
only that much.
Yeah.
Now I request Rekha to start her talk, and kindly be brief, Rekha. You know that we have less time. Yes. Maybe you should. Yes, please. Yes. You are seen very well. Continue. Make it slideshow. Hello, Rekha. Hello. Hello. Hello, Dr. Rekha Gurumurthy. Hello. Is there a problem?
Madam is there, but her network is.
So can we?
Yeah.
Can see her now. Dr. Rekha.
Okay. Rekha, can you start talking, please? And hello. Oh God. Hello.
मैम मे बी ऑडियो में प्रॉब्लम है
Rekha, can you unmute?
मैम वो अनम्यूट ही है रेखा मैम
She can go out and join again, I think.
Yeah, that may be possible. And meanwhile, we can ask her to stop sharing so that we can conclude the discussion and maybe give her time in another session. Rekha, can you speak? Hello?
Better to go
Yeah,
for the
you're
next.
not audible, dear. Some problem with your audio.
Go for the next speaker. That will be right.
Yeah. Yeah, you're not audible. You're not audible. I'm so sorry. Can you stop sharing so that we can conclude this session because we are running late by 15 minutes or so. So we will give you time again in the course of the program. Thank you so much, Rekha. Please stop sharing, dear. Sorry for that. So I think now if we can have some concluding comments, we should move ahead because we are late. We did lose time. I don't know how it happened. I think it was just in the flow of discussion that we have lost time. Dr. Anahita, on this vulnerable population segment, do you have anything to add so that we can quickly conclude?
I think what Dr. Air Commander Sharma spoke about was extremely important. And we need to be open to having populations who are diverse. And we need to also be up to the mark on what we can advise them. We cannot say, I'll check, I'll do this, I'll come back, because
correct.
that doesn't
Even I
make
was
sense.
looking forward to what we should do when a when a transgender comes in, when we realize that they are at risk of unwanted pregnancy.
Correct.
How to go about
That
it.
is number one. Number two, I think Dr. Mrinalini spoke very well about post-abortal care. You know,
Yes.
in the past, we all in the government hospitals would say, either you take contraception or we are not doing your MTP. So we
Yeah, that's
can't do
wrong.
that anymore. And we need to give them contraception the moment
Yes.
they are in front of us. I
Correct.
think for certain populations, it doesn't make sense to say, think about it and come back. We need to also dive, you know, kind of push them towards what we want them to do, even though that is against whatever else we may believe. But we need to also think about what they need to be accepting. And it becomes very simple. IUDs or implants or injectables become very easy to institute at the same sitting or at the first follow-up. So we need to do this. And I think all of us, I think, have given our 2 bits. And
Yes, yeah, it has been a very fruitful session.
Yeah.
And with that, I think we shall move forward. Anupama, I think for lack of time, we will restrict the interaction to this much. Thank you so much for joining all the way from Varanasi. Thank you, Dr. Sharma and Dr. Sanjay Sharma both. Thanks a lot. Sorry, Rekha, about that. And thanks a lot, Mrinalini. That was very valuable. And the first, with that, I would like to, Rachna, can we go on to the next session, please? Yes.
Thank you so much. Thank you, Dr.
Yeah.
Shobha. Thank you, Dr.
Thank you.
Parag, and everybody at ICH.
Yeah, correct. Yeah, session 2. Yeah. So, Rachna, you'll introduce? Hello?
Shobha, you can go ahead.
Yeah. So Indra Polo also has been part of my team, Sankalp team, when I was, she's from Berhampur. So she has worked with me when I was chairperson. A lot of work she has done in PPI UCD, and she has contributed a great deal to family welfare in her region from Orissa. She is the secretary of Berhampur OBG Society at present. I welcome you as chairperson, Dr. Indra. Next, please. And of course, we have Dr. Rajeshri Katke, a very well-known teacher, senior professor, head of the unit at Grant Government Medical College and ex-superintendent of Karma Elbless Hospitals, Mumbai. Welcome, Rajeshri. I'll not attempt to introduce you because, you know, it is so kind of awe-inspiring, your CV. I will not be able to do justice. So I welcome you to introduce the speaker and take it forward. Thanks a lot. Thanks a lot. Yeah.
I think today's speaker is Dr. Manju Puri ma'am. She is a well-known figure to all this fraternity. And ma'am is director, professor, and former HOD department of OBGY, New Delhi, LHMC, Lady Harding, chairperson of the Safe Motherhood Committee of Association of OBGY, Delhi. The national coordinator, practical OBGY committee, and she has many of the, I think we have listened to her, and she is a very good, I mean, the CV is very big. Ma'am has edited books, written books, and we have worked with the internal ILAC ligation, with the practical obstetric committee, and everybody knows her. So I think ma'am is a very good academician, researcher, and a great administrator too. So, ma'am,
thank you,
Dr.
Dr.
Manju, ma'am.
Ashwini. Yeah, thank you so much.
It's a
And I'm
pleasure
sorry
to
for the
introduce.
CV. This is an old CV, so I'm.
I know. So I have
So
put
no,
it
that's
more in
fine. That's
that.
fine. So I am presently working as senior professor at SGT Medical College, Gurugram. So I've superannuated from Harding, right? And thank you, Dr. Shobha and Dr. Parag for having me here. And I am absolutely floored, Dr. Shobha, with the topics and also with the selection of faculty. So very insightful, deliberations on contraception, and love your passion, right? So with those words, and thank you, Dr. Ashari, for all the kind words. And I'm here sharing my slides and moving further on postpartum contraception. We'll be looking at the programmatic interventions, what can make it work. So contraception is recognized as a key enabler for improving the health.
Manjuji, just a word of caution. Just support me with time limitation today. Thank you so much.
You can give me a tinkle at 1 minute, right? I'll close, right? Okay.
Manju ma'am, slides are not visible. So
Okay.
please share the
All
slides.
right, I'll share them again. Just a
Yes.
second. Okay, yeah, I'll share them again. Yeah.
Open hai presentation.
Yes, open है. Just a second. Yeah.
Actually,
Just a second. Yeah. Is it visible now?
yes, ma'am, please go
Yeah.
with the slideshow. If you can go, that will be better.
Yeah, I will. Yeah. So I think it is there now, right?
Perfect.
Okay.
Now,
Has it gone or it is still there?
It's okay, Dr. Manju, please go ahead. Fine.
All
Yeah,
right.
it is fine.
I can't see it now. Where is it gone?
We can see it very clearly.
Shobha, but I don't see it.
ma'am, just forward it. It will come the next slide and then it will be visible.
All right, just a second. Just a second. Mm. Stop share. Is it visible now?
Yes, ma'am.
All right. So, contraception is recognized as a key enabler for improving the health and well-being of women and children worldwide. Unintended and closely spaced pregnancies are associated with a range of negative maternal and child health outcomes, like increase in MMR, increase in infant mortality rate, preterm births, low birth weight babies, stunting, maternal depression, and even intimate partner violence. So WHO recommends an inter-pregnancy interval of at least 2 years. International estimates of the unmet need for postpartum contraception is as high as 62% in the first year following childbirth. So that is a huge unmet need. And increasing the use of postpartum contraception has been the target for a number of policy initiatives globally. Now, what is the purpose of postpartum contraception? So it is to help women to decide on the contraceptive they want to use and to initiate that contraceptive, and also to continue contraceptive use for 2 years or longer, depending on the reproductive intentions of the woman or the couple. So we have two groups of people. One are spacers. Postpartum contraception addresses a need for those who wish to have children in future, but they want spacing. So they are spacers. And the others are the ones who have reached their desired family size and wish to avoid future pregnancy. So they are the limiters. So it kind of looks at both these. And I think it is a very good opportunity which we should not miss. So the average time to first ovulation varies between 6 weeks to 12 weeks postpartum, with the earliest reported ovulation at 4 weeks postpartum. So, if she becomes sexually active within after a month, she can become pregnant again. And 50% of the women would resume sexual activity before the 6 weeks postpartum visit. Hence the importance of counseling before we discharge them from the hospital. The overall use of contraception in India has increased to 66.7% as per NFHS 5 data, but 27% births occur within 24 months of the preceding birth, before the WHO recommended birth interval. So that means this 27% should not have occurred because it was in less than 2 years. Hence the importance of programmatic interventions. Now, this is a very good manual of WHO, although it is old. So this gave the programming strategies for postpartum family planning, and it gives a postpartum family planning program model. So here there are, health system building blocks, which are listed here, which are actually pivotal in providing in-service delivery or delivering service as far as postpartum contraception is concerned. And this then leads on to, improvement in process indicators, which would be coverage, contraceptive, counseling coverage, quality of the care which is provided and the contraceptive use. And then finally the outcome, it impacts the outcome indicators, which would be the mortality and morbidity and also the fertility potential. So this is the model which would kind of on which various programmatic interventions would be built up. Now, what is most important as far as postpartum contraception is concerned, that it is an integration, or it provides us with windows of opportunity. So postpartum family planning should not be considered a vertical program. So not that something which has to be delivered only in the postpartum period, that is 6 weeks period, but rather as an integrated part of existing maternal and child health and family planning efforts. So a comprehensive postpartum family planning intervention entails continuity of care for the woman and a baby at many points of contact in the health system over a relatively long time horizon. That is from the antenatal period to the 12 months after birth, or that is the extended postpartum period. So we should start thinking about or helping or counseling the patient right when she comes to us pregnant. Right? So it is not that a pregnancy is what should be the focus. It should be the focus. At the same time, start discussing gently as to what are the options available, and especially the options which are available right at the time of delivery. So, then labor and delivery is the second important point. So someone who's missed in pregnancy can be, roped in at the time of when she's admitted for childbirth and, pre-discharge. And then, of course, in the postnatal period, that is from 48 hours to 6 weeks period. And then finally, when she visits the hospital for her immunization of a baby or some problem with the baby. So these times should be tapped. Now, if you look at the building blocks which were there in that model, as regards the health, the first was the health workforce. So we have ASHA workers, we have ANMs, we have medical officers, we have specialists and consultants who are, supposed to be responsible for delivering postpartum contraception. But I think this net needs to be increased, and more of Ayush doctors, nursing officers, doctors from other specialties. Why should pediatricians not be talking about contraception? Why should we have a person there talking about it? Pharmacist, and of course, we need to onboard healthcare providers from private sector as vigorously as we would push the public sector, because everyone needs to talk about contraception. Then it is important that when we have a health workforce, there should be capacity building and task shifting. So, there should be systems available for staff development, for national tools or guidelines which are available. Task sharing would mean that, when I talk about pharmacists, when I talk about pediatricians, when I talk about other specialists, so everyone should be, sharing this task of counseling for contraception. Of course, we need skilled personnel. We also need to rope in community health workers, because they are the ones who will connect with the patient and do home visits. Right? So the patient comes to us and then she goes back to her home. So there should be, she should be time and again reminded of the contraceptive methods. And also, when the patient leaves the hospital, she generally, she might leave, she may not offer for a LARC, that is long-acting reversible contraception like IUCD or an implant. She might say that I will go for, I will observe abstinence, or I'll go for, condoms or something like that. But then subsequently, they would need a switchover. So that switchover also needs to be kind of reminded to them, and they should be taken on board. Of course, pre-service education, in-service education, and of course, performance monitoring are the various ways by which the health workforce can be improved upon. The various, how do we strengthen human resource capacity? So policies and practices to address staff development, we've already said that. And of course, retention of the staff who is trained to be providing, family planning services. There's a quick switchover. So it is important they are available within the ANC, labor room and PNC areas. Introduce and strengthen a comprehensive reproductive health education curriculum, right? And also integrate the concepts of postpartum family planning with pre-service education. and dispatch mobile outreach teams to facilitate in the short term in order to provide services. We're building capacity of staff for the long term. So initially someone can go there and then start counseling and start imparting the services, and at the same time training the staff which is already there. Then, the second building block is the, hospital management, information management system, right? So it is important that all the key indicators of postpartum coverage and contraceptive usage are monitored. So it is not only for the government public hospitals to do this, even the private hospitals can monitor their own key indicators, and everyone should feel responsible for population stabilization and for family welfare and planning. And continuity of care tracking. So, if you start that policy of counseling patients from antenatal clinic and then track them and see them, how many of them actually accepted contraception in the postnatal period. And of course, a lot of surveys and research needs to be done to find out what is it that the people want, and what are the trends, and then identifying the gaps and then treating them and correcting them. So if you can't measure it, you can't improve it. So it is important that each one of us would, look at the indicators. Dr. Shobha had given you an example of an indicator where we talked about the unmet need. So indicator is a measurement tool, which is actually a ratio. So it is used as a guide to monitor and evaluate the quality of healthcare, or quality of, if I'm talking about postpartum, so quality of postpartum care we are imparting. And it is a tool to make continuous improvement in quality of care. So we know that we are at, say, 10% or 20%, and next time we will try and make it 30%, 40%, and look at what the gaps are so that we can continuously improve upon our postpartum coverage. Now, looking at the indicator, so, I will skip this. Then building block 3 is the medicines and technologies. So, procurement and supply chain has to be maintained, and all kind of contraceptives, that basket should be there. And of course, the logistics information can be electronically monitored. And, that also will be a key indicator if there are short supplies, and also that is also going to give you an area where you can work upon. So we have this contraceptive wheel, which is a very beautiful tool, which everyone should have, and it helps us in guiding people as to what contraceptive is best for them. So, if you look at the postpartum contraceptive, so it tells you that within first 48 hours, we can give everything except for combined pills and DMPA and, the injectables. And if we look at 48 hours to 6 weeks, then we are, left with, we can't give COCs, injectables, and also the IUCDs are out, right? But if we go from 6 weeks to 6 months, it is only the OCPs which we can't give, rest all can be given. So I'm saying this wheel actually helps you in understanding what to give to the patient, what time. We have this big basket, everything can be given except for combined and injectable program, contraceptive. Implants are a big shot in the arms of doctors as well. It is not only in the moms, but also in the doctors, because it is a very good method which can be offered. People don't want to have anything inside the uterine cavity. They are okay to have it in their arm. So we should promote it. So these are the contraceptive methods. There are other building blocks for programmatic interventions. Financing is one. There should be special funding for postpartum contraception if we want to push it. And also in private sector, there should be a bundling of the contraceptive part with the delivery package, so that it is a part of it. And of course, private partnerships, and of course, leadership and governance is something which is important. Our government is actually giving it a good push. And of course, community participation. This has been discussed. The male participation is important, and it has to be family who has to be counseled, or the couple which has to be counseled, and not the woman herself alone. So these are some interventions which are to be done at the community level. So it is important that contraception is talked about at every home visit. And of course, we also need to promote lactational amenorrhea method, and also essential breastfeeding for the first 6 months. So this will improve both the maternal and fetal outcomes. And it is also important to understand that the first-time mothers are the ones who should be targeted, and also the adolescent mothers need to be targeted, because they've already proven their fertility. So after that, they should be encouraged to have spacing, and different methods, depending on whatever they choose, they should be kind of counseled. But please remember, the counseling has to start from the antenatal period and should be done continuously. So this, I said, bundling of postpartum family planning with the birthing package to ensure that all contraceptive methods are covered during the extended postpartum period. This is for the private sector. So these are certain facility based. And moving on to summarizing, there is a huge unmet need for postpartum contraception, both in public and private sectors. The healthcare providers who can provide postpartum counseling must be expanded. You know, we need to have more people. Hello?
Yes, please conclude.
Please continue.
So the postpartum family planning needs to be integrated with ANC, care during childbirth, and extended postnatal period up to 1 year after childbirth. Counseling must address the needs of the spacers and limiters. And it is important that those who want to, who have finished, completed their desired family size, they need not be pushed for, sterilization. They can be always educated that there are many more methods which are available now, which are safe and they are long-term. Tracking and continuity of care is important to help clients with problems related to side effects of contraceptive methods and transition to other methods. So that is why a continuum of care is something which is more important, and also the follow-up care. So postpartum family planning needs to be bundled with the birthing package to ensure that all contraceptive methods are covered during the extended postpartum period. Both public and private providers must be involved in promoting postpartum contraception. So we have good program, but I think the program is not, involving the private providers so much. So I think that is where the government needs to focus on. Thank you so much for patiently.
Thank you, Dr. Manju ma'am, and it was very enlightening and very nice, because you involved both the PPP public and the private with the government and all. What I would like to say that postpartum contraception, we have a huge unmet need of that, and the most important thing is that either from the government and the private sectors, providing the right approach toward the patient is very important. We are having, because PPIUD is the one where the patient is, as you rightly said, that it starts from the antenatal till it goes to the 2 years of the counseling. Sometimes the patient, they do come, and this 2 year span is very important to reduce the mortality and even the morbidity of that, and that very nicely been explained in that. And I would like to say, we had the program of the Implanon Norplant in Grand Medical College, and that was also run very well accepted, apart from these PPIUDs. And definitely we are supposed to take the medical eligibility criteria. That is very important. Then what suits to the women, that is the second important thing.
Yes.
Follow-up of the women is very important, and this will give rise to the good contraceptive counseling is a very big part of that. Because once the woman is delivered, and if she's going to get discharged, then she says, I'll come after 2 months and 3 months, and that 2 months never comes to us in that. So this is very nicely explained to you. And even with the government policies, like what you rightly said, even the Janni Shishu Suraksha Yojana, Janni Shishu Yojana, in that also. And I would like to say one point in that, for the spacers, it's very good, but for the limiters, we should concentrate on the male sterilization, non-scalpel vasectomy also. That is the part, though we are the gynecologists, but that is one thing which even we are supposed to create an awareness and give the opportunities for this. I think in all, it's a very comprehensive enlightenment talk from Dr. Manju on this postpartum
really delighted.
And
Thank you, Rajeshri.
Dr. Shobha ma'am.
Really delighted that both of you in the limited time, you really gave a power-packed performance, and I'm so happy that you were chair, and of course Manjuji was the speaker. Wonderful talk, Manju, and I think it has come from your heart, because this is what you have done. So it is something which you have executed on ground, and that is the reason you have such a hold on this. And I think we had Basab is right there as the moderator now. So I must say that in their AICOG, Dr. Leslie Regan was there in my concluding workshop. And thank you, Basab, for that opportunity. And she very rightly said that immediate postpartum contraception can be given to the woman in her in the uterus or in the arm or in the purse, and she can go home with one of the methods in place. So very well brought out, Dr. Manjupuri. With that, we transition to that much awaited panel discussion on applying MEC criteria. The floor is yours, Dr. Basab. We'll not interfere now for the next 40 minutes. We bear with the audience to just stick on, because a young brigade is there who will be answering all the questions fired to them, and Basab will take it forward. Thank you very much.
Thank you, Shobha. Warm regards to Parag and the team of ICOG for doing a wonderful job and bringing this certificate course here. Conveners, Dr. Shobha, who's carrying on with the flag of family welfare after her chairperson of FOGSI. She hasn't stopped, whether it's ISOPAB, whether it's ICOG, whether it's other things. It's always Shobha leading the way for the family planning seminars, webinars, any academic value and other than thing. Dr. Rachana, Dr. Durga, I can't see my friend Durga Das, and the coordinators, Dr. Kavita Agarwal and Dr. Riju. So just we're starting a panel. I don't think it'll be 40 minutes, it'll be much less, but we have our panelists and the idea is just to hear from them, and we'll make it start. Good to see Mukta here, and Dr. Amrita is here, and Dr. Priya is here, and Dr. Prerana is also here. Fine. So I think we'll just make a start and then take it from there. So again, thank you very much for this opportunity. Once in a while, we also get a chance to come to ICOG and have some discussion, and it was a really wonderful discussion preceding this. I agree I echo the words
that
of
is
Dr.
a hint.
Shobha.
That is a hint, Basab. You were not there for a long.
No. Means like you guys do such a wonderful job. Like
I would
always
take the
wonderful
hint
to
any
be.
day.
It's always wonderful to be also counted once in a while. So it's really great. But Dr. Manjupuri, of course, brilliant as usual, and I'm a very big fan of hers. She knows that, and she does so excellent work and so succinct and clear in her messaging. So do we have our panelists? I'll just run them through. So Dr. Amrita, are you here?
Yeah, yes, sir.
Yeah, Dr. Amrita, you're here. Dr. Meeta is here. I saw her somewhere.
Yes, sir, I'm here, sir.
Dr. Meeta is here. Mukta is here. Dr.
Yes.
Prerana is here. Dr.
Priya Gupta.
Priya Gupta is here.
Sushma.
Dr. Shushma,
Yes.
are you here? Yeah,
Yes,
Dr. Shushma is here.
sir.
Oh, wonderful. So everybody's here. So thank you. So that's wonderful. So let's start the ball rolling, and over the next, let's say, half an hour, we won't do longer than that. So we won't keep all of you wait. We'll just save 10 minutes for Shobha. Shobha will give me a chocolate later for that. So hi, Durga. So nice to see you. My friend Durga Das is here, the convener of this program. Thank you, Durga. Thank you for having me here. Thank you. So over the next half an hour, what we discuss is medical eligibility criteria in practice to improve contraceptive uptake. That is the topic. And Dr. Manju has already shown us the wheel, which is the medical eligibility criteria. So before we start the ball rolling and before we have the medical eligibility criteria discussion, could I like to ask my panelists one by one about whether you use MEC? What is your general thought on that? Do you think it's a useful device? Do you think it's overstated? We normally give contraception without referring to it, or it's not that important? Can we start with Dr. Amrita, please? Dr. Amrita, we would like to hear we know what MEC is, of course, and we know it's for contraception, of course, and we know the basics of it. 1 and 2 you can give without thinking. 3 and 4 you really have to wait and watch. So do you think it's what is the clinical implication? I would like to ask. Do you use it in your clinical practice? Do you think it can be or it's better in the community rather than in the city? And what you generally think about it? Then we'll hear from the other panelists. Dr. Amrita, please.
Yeah, so thank you so much for giving me this opportunity. Yes, sir, we use this medical eligibility criteria in our clinical practice, of course, for the safety of the patient which is much more important. Not by going by each and every intricate details, I must say, but yes, the basic criteria for giving, when to give COC, when to give POP, when to give like IUD or LNG IUD or what are the things. I think medical eligibility criteria is here to stay, because we can't just give everything to every patient. We can't like fit them in one approach. So we have to follow that for safety.
Correct.
Precisely.
So Dr. Prerna, can you come in and you unmute yourself? Yeah.
Yes, yes.
So for safety is one. I think safety is a very important thing, safety of the patient and safety of the doctor, because both of us, we need to be safe. And I think that's a very important part of it. But let's hear from you in what you think is the clinical utility of the medical eligibility criteria. That's what Shobha wants to hear from all of us, whether we use it in our clinical practice, whether you think it's better in the community rather than in the city, or whether you can really mug it up, or whether around 40 people you don't much give something risky in contraception. Can you just
So very much agreeing with Dr. Amrita that we are not going into the intricate details definitely in our clinical practice in the day-to-day scenario, because what we want overall is that we shouldn't, the MEC 3 and 4, as you have said, that we need to outweigh the risk over the benefits, and then the benefits over the risk whenever it is pertaining to us to every patient that we need to see. And what we need to understand is that we have to go through the entire history of these clients, because they might have a history of DVT, which they might actually may not tell us and say, maybe feel that that is not very significant when they are coming to us for contraception. So a proper history taking for every patient to find out whether they fall into which category, whether they fall into 1, 2, 3, or 4. Because 1 we are okay with it, we can give with haywire. But then if in case we are missing out on the history, and then we feel that it is 1, in today's world of chronic diseases, even a person lesser than 40 might have an episode of vascular thrombosis and all. So we need to take the history, that is very, very important, to make up all these patients into a particular criteria that we might miss on in our clinical practice.
Thank you, Prerna. Thank you. Dr. Meeta Gupta, ma'am, will come to you. You've heard from Dr. Amrita and Dr. Prerna about clinical utility. Can we hear from you, please? Yes.
Yeah, so we being government teaching institutes, I think so this is in a very simple word we could say, it's Gita. Once it comes to contraception, especially for our postgraduates, we have it in all our consultation rooms. Every postgraduate is supposed to consult that wheel of medical eligibility criteria, because 90% of the times we would not require it, but it is usually the 10% where we would like to refer to this. And we make sure that all the postgraduates from the very beginning are into the habit of referring to this wheel for their contraceptive choice. Thank you, sir.
Thank you, Dr. Meeta. I think very important points. Priya, coming to you next. The very important points coming up that, first of all, yes, it has some utility in a clinical practice, especially in a teaching institution, especially inculcating that habit. As Dr. Meeta very clearly said, in 90% cases, you won't need it. You would be able to prescribe contraception, reasonably sure. And then the very highlighting, as Dr. Prerna said, the history taking, so important that you don't miss out on the medical history, on the family history, which can put you in trouble later if you haven't really got that and you prescribed something which was unindicated and harmful. Priya, I would like to hear from you how you would like to place medical eligibility criteria. How do you utilize it in your clinical practice, and what your thoughts are on that?
Good evening, sir.
Right.
Sir, actually, I'm working in a corporate and a super specialty center. So I do encounter patients where I need to brush up my skills and seek help from some scientific evidence-based structure. So I feel MEC criteria which are given to us, they are definitely an evidence-based things, and they provide us with the latest of the scientific evidence. So, and they're 100%, I do incorporate in my practice, because we are getting cardiac patients, we are getting diabetic patients. We need to be really scrutinized before prescribing any of the drug. And when we think on the other aspects, it is also giving us a medico-legal safety also. being into a private sector. So I think that is 100% justified, we are using in our OPD or IPD patients.
Thank you, Priya. Thank you very much. We
Thanks.
move to Mukta, Dr. Mukta Agarwal, a skilled laparoscopic surgeon, managing committee of IAG, but Mukta is wearing a different hat here. She's now into contraception. We've got her into, and Mukta, we want to hear your thoughts on medical eligibility criteria. And this is, we're talking about the clinical utility, or how much you think it is used clinically. Do you use it personally clinically? You think there is a utility? And if you want to share your thoughts, please.
I use MEC personally because I'm also a medical teacher. Most of the points are covered here. One thing which I would like to add upon that MEC, WHO MEC criteria, this is using worldwide. So this is something which is not very subjective and varies from clinician to clinician. So if I'm saying that this is MEC category for like for postpartum women, if we give COC, so anyone in the world will approve the thing. So we will all be speaking in the same terminology. And that is very important, that it is not the practice based, but it is something which is followed uniformly. So that uniformity is also very important when we are talking about medical legal teaching, because when our students, they are going to international platform, they are also speaking on the same language which other students from the other countries are speaking.
Yeah, Mukta, that's another point. Dr. Shushma Sinha, Dr. Shushma will bring you in here. You've heard the other participants bringing out their thoughts and their points on medical eligibility criteria. We want to hear from you, ma'am. What would you think, whether it's utility and how you place it in your clinical practice, ma'am?
Good evening, Dr. Basaf sir, and good evening to my panelists and all the young students listening to this. And thank you, Dr. Shubha ma'am, and all the stakeholders. Yes, working in a public sector as HOD Gynae, I first laid my hands on this very important tool way back in 2014 when it was blue in color. And it had only, five the contraceptives that were in offer. But gradually it became saffron, and now it is green. So they have added Centramun, which is our own indigenous product. And it is a very important tool, must have in all the OPD rooms, and it has objectivity. And as it can be shown on the slide, it deals with all the nuances and finer aspects of the contraception, like the failure rates, the effectivity rate, and all the initiation, continuation, the very smallest of small things have been added, and it is a wonderful tool to have. And now GEO has developed a software also, and the students can refer to that as well. And when I got this tool way back in 2014, it was very far and few in number, and I got it from HOD AIIMS. That time, Dr. Sunita Mittal was HOD AIIMS, and it was a news in the area that it is available. You can go and collect it from there. It is such an important tool. Until last 10, 12 years, we have been using it without fail, and it is useful and very handy. And of course, you can carry it anywhere.
Yeah, thank you, Dr. Sushma. Thank you for your inputs. Yes, issues to address, as we said, shrouded with myths and fears of the unknown when you are prescribing a contraception to a woman with a medical condition, also possibly at extremes of age or some lifestyle issues. Some conditions can give a perfect excuse for the woman not to use contraception or the healthcare provider not to prescribe one. But at the same time, it's so dangerous for people to get pregnant when you have uncontrolled blood sugars, uncontrolled hypertension, and those are the issues. So risk of pregnancy versus the risk side effects of the family planning is something which you have to weigh upon it and decide on which one is more risky. So most of the times, I think the risk of pregnancy is more risky, and that's the reason why you really have to choose, as we rightly put up by our panelists, which one to use and in which particular condition. And so nicely being portrayed by our experts about the different utility clinically, and a history taking, which was very well stressed, your personal history taking, especially your lifestyle. A lot of women smoke nowadays. So smoking does come into the picture when you're talking about hormonal contraception. family history, past medical history. Those are things which you just cannot scribble some on the OCP on a newly married. You just have to take some history, because a lot of people get married also late. They get married at 35, they get married later, and she may have developed some medical complication which may help you to choose one over the other, or one may be more risky in her case than something else. So very rightly put by Dr. Sushma ma'am that about the blue wheel, we used to get it from WHO. We used to order it, and then they used to come on mail at one point of time. And from there, of course, we have moved on to the app, which will be coming to some discussion later. So here is the MEC for hypertension, let us say. This is a one discussion point, and I think that is one of the reasons why we check blood pressure for everybody, especially with people with uncombined oral contraceptive pills, because if they are high, then there is a hesitancy, of course, to give oral contraceptive pills. We'll come to Priya. Dr. Priya Gupta, can you please share in your clinical practice, how does hypertension come into selecting contraception in your case? So a lot of women, you said your clientele would deal with a lot of people who are in a high risk situation before. And so how does exactly, what type of a contraception do you choose in these cases? People who are pre-existing hypertension, or maybe borderline when you first check her, when you're giving her the OC pill?
Yes, sir. Sir, in a case of hypertension, suppose if the blood pressure range is between 140 to 160 systolic and the diastolic is less than 100, in such cases, we can offer patient as MEC1, POPs, the LNG IUS can be offered, the implants can be given, copper IUDs are safe. But when a patient is actually reporting with the hypertension, in such cases, the DMPA is taken as MEC2 criteria, and we take combined hormonal contraceptives as MEC3. And suppose if the patient blood pressure is reported to be more than 160 by 100, so in such cases, copper IUDs are the safest choice, and even the progesterone only pills or the LNG IUS or the implants, they are being shifted to MEC criteria 2 with DMPA as MEC3 and the combined hormonal contraceptives as 4, because the DMPA favors atherosclerosis, and the patients of hypertension maybe have an added risk factor if DMPA is being given as an initial choice. And suppose if a patient comes to us with vascular diseases, then definitely again copper IUD should be our MEC criteria 1 choice, with POPs, LNG IUS and implants as MEC2, and again DMPA as MEC3 and the combined hormonal contraceptives as MEC4.
Yeah, Priya, just interrupting you. Dr.
Yes.
Amrita will just get you here. I want to know that if you are giving a person a contraception, you have a blood pressure of 140/90 in the clinic.
Yes, sir.
Are you happy to give that, or are you not happy to give that? That was my first question.
Happy to give what, sir?
Combined
COC?
oral contraceptive, COCs.
No, sir. It's a category
Sir,
3, I guess, MEC, when we
sir,
are coming to like
sir,
systolic
if it's
BP
like
in between. Yes, ma'am.
no, sir, sorry, please.
Yeah, let Amrita complete, then Priya will come back to
Yeah,
you. Please.
if it is like in between the systolic BP you are saying, sir, in between 140, above 150 or 140 or so, then COC is not much preferable, sir. In that case, as ma'am said, the most like safest bid will be copper IUCD or LNG IUD or LNG implant, whatever. We
So
shouldn't
I
go
think
for
the first
CIC.
dilemma that a lot of us have is whether she really has hypertension, because one reading of 140/90 in a doctor's clinic could be anything, and a white coat
Yes,
hypertension and so much of things.
Yes.
We really don't know whether she is a hypertensive. If she's hypertensive stamped and she comes there with medicines, of course you look at this and everything. But if you
Yes.
don't know whether she's hypertensive and you just get one reading of 140/90, you'll be skeptical to know whether really to follow that or not. You'll tell her to check her blood pressure at home and then possibly hold on to something and then give her back something else. I think most of us would be doing that. Dr. Prerna, can we get you
sir,
in?
can I add up?
Yeah,
Here.
please. Yeah, yours.
Sir, if a patient of 140/90 comes to us and we are in suspicion of this patient having hypertension, we should also take into consideration her lifestyle, the obesity, and the risk factor of being a smoker or non-smoker.
Right.
I think these criteria with borderline hypertension have an additive risk, and we need to be really cautious using COCs in such patients.
Yeah, Priya, I think the important thing is that you have to look at the patient at the whole. Obviously,
Yes,
we're
sir.
not looking at contraception, just the contraception, but here the discussion is on those lines. But of course, if there's lifestyle to be corrected, if there's BMI to be checked, if there's other things to be not done, then those boxes need to be ticked. Prerana, we just want to hear from you.
Sir,
Blood pressure,
as yeah.
contraception.
Yeah, so blood pressure, as you rightly said, that a single monitor cannot, single-handed, like first visit checkup cannot tell us that she's hypertensive. So it's very well said that we need to monitor her progress or monitor her blood pressure readings and then find out whether she is eligible for that or not. But when we consider, like Dr. Priya has said, that she's not fit for COC, give her IUD, LNG, IUS or this. But this we cannot do because we have to amalgamate what are her personal preferences. She is not diseased. She is not diseased. She has come to us for something which is on a regular basis. She wants to take some pill so that she doesn't become pregnant for a period of 1 year, 6 months, 8 months. So we cannot just tell her that you're not fit for COC. I want to put an LNG IUS inside you. She might not go for it. Even if she's eligible for LNG
Yeah,
IUS.
I think what Priya said is that you give her, you take the options, but some of the things like you will give her options depending on what options she has. Like there are some options because of the MEC that she will not have, and so sometimes like if you stamp her as hypertension and quite elevated, and she's already on medication, then the hormonal, the estrogen containing pills go out, and as concerns with DMPA was raised, that also is a concern.
Definitely, we need to go through the evidence-based recommendation as MEC criteria is giving, but we need to also look upon the personal choices of the patient that is concerned.
Correct. Dr. Meeta, would you like to come in? Ma'am?
Yes, sir. I think so. I would agree with Dr. Prerna. With the advent of such new good antihypertensives, I think so we can easily use an OCPs if the patient wants and is not willing for an IUCD. With an antihypertensive, both would be working wonders, giving the patient contraception as well as taking care of the antihypertensive, sir.
I think that was the point. Mukta, Dr. Mukta, is there any particular OCP you will, combined oral contraceptive you will use? Would you be tilting towards drospirenone versus LNG, or is it all the same as far as hypertension is concerned? Mukta.
The drospirenone containing are, I guess, safer. But if they're uncontrolled hypertension, then definitely we will avoid the choices of COCs.
Correct.
And if the hypertension is controlled, then still with the counseling, if she opts for COCs only, then she might get the COCs. Otherwise, she has other safer alternatives in her basket.
Yeah, Dr. Sushma, we'll bring you in. We haven't heard from you in some time. Dr. Sushma, if you can put your video on. Would you be, what about progestogen only pills? What about ormeloxifene? Does that come into your things? What would you do?
To put the matter into perspective, OCP is the one which has a red mark, like category 3 or 4, according to the hypertension and comorbid conditions. Otherwise, rest of the contraceptives are quite safe, as in copper IUCDs, the LNG IUS, the Centroman, the POPs, and the implants. They are all safe. And the MPA, like MPA or NETN, it is again category 3 if we have, high range of BP, blood pressure. But we should be also looking at the comorbid condition, how long-standing that hypertension is. And there are various other factors which has to be taken into consideration before we actually it has to be tailor-made. It cannot be said like ek hai, do hai. It cannot be commented upon that way.
Very
It has
correct.
to be
I think
tailor-made
we'll
and
take your
customized.
point, Dr. Sushma. Absolutely, very well taken. That you have to tailor-made. It has to be individual choice, and it has to be taking into multiple factors, like not just one reading of hypertension. Again, you look at BMI, look at obesity, look at family history, look at other conditions, look whether she is in a risk of arterial venous thrombosis, arterial thrombosis, venous thrombosis, and all that. We have to make a decision. So the purple calendar, as you rightly said, was done by India. So the blue one was the WHO, the one. The purple one was done by India. So AIIMS had done it. I think Dr. Alga Kripalani or Dr. Sunita Mittal was at that time at the AIIMS Helmholtz. I think from Bengal, from Foxy, we were also invited when this was being made in 2015-16 was when this was actually, they started doing it. So some rapid fire questions. I'm having an echo. Why?
Yeah, there is an echo, Basu.
I'm only one device. I don't have any other device.
Someone has joined with 2 devices.
Host, please sort it, please.
Okay. So
Okay, there is one question on availability of the mech wheel. Please answer that.
Oh, okay. Coming to it. It's a little later. Just hang on, hold on to the episode, and in the next 10 minutes you'll hear the app. So rapid fire. Let's see. Let's start with Dr. Meeta. I can see you here first. Postnatal more than 6 weeks, low risk of VTE, non-breastfeeding, combined hormonal contraception. Yes or no, ma'am?
No.
Not breastfeeding, low risk of VTE, postnatal 6 weeks.
Yes, yes.
Very,
Yes,
very favorable for intrauterine IUCDs. No, sir, I am very favorable for intrauterine
Fine,
IUCDs.
fine. But again, ma'am, it's not your choice; it's the patient's choice. So
Yes,
we
yes.
all have our individual favorites. We all have our ones which we like, of course. But I guess at the end of the day, we have to have a.
Sir, not breastfeeding. Definitely OCPs can be given. sir.
OCPs can be given, but as you said, IUCD would definitely be a better choice in the long term if you are able to convince her and she is able to understand that and comply with that. Dr. Priya, varicose veins, combined hormonal contraceptive, MEC 1, 2, how would you put that?
So
Can you
in
use it? It doesn't
varicose-
matter 1 or 2. Can you use it is, I think, more important. Combined hormonal contraception, can it be used in varicose veins?
So they can be used definitely, but we have to do counseling regarding the risk of usage of combined hormonal contraceptives in such patients, and we need to properly scrutinize a patient of varicose vein coming to our OPD. We should get the Doppler done initially so that the statics, grading should be done before we give the patient as combined hormonal contraceptives, and the risk to be really explained and follow-up should be mandatory.
There's some thoughts like superficial varicose veins has nothing to do with deep vein thrombosis, but at the same time there's some people who say you should be cautious and you should be careful. But there's some thoughts that varicose vein has nothing to do with the DVT, and so those are some thoughts by some surgeons out there. But again,
Yes.
I think you have to have a very
So though
careful
the
approach.
criteria, it says that in case of varicose vein, all the contraceptives are MEC1 criteria.
Yep.
But when it comes to a superficial thrombosis, then definitely copper IUD implants, I think they are a far better choice. DMPAs and CSCs are taken as a MEC2 in such patients. So I think counseling again, taking into consideration the patient faith, and if they understand it, they come in close follow-up. That
Yeah,
will be the
again,
more deciding criteria.
again, I think, again, as we all discussed together, that you put in the choices in front of them, they make the choice. Sometimes you say some choice may be better than one, depending on her condition. I think that all of us agree. DMPA use in less than 6 weeks postpartum. Prerna, Dr. Prerna, you'd like to come in?
Definitely, sir. DMPA use will cause a lot of bone density, bone mineral loss. And so we have to, in less than 6 weeks, if she is breastfeeding, then definitely we are considering the risk and the benefit. So I would rather consider it as a no in my clinical practice, but that will depend on the personal choices and how well you can counsel, and how much more nutritional support can be given to the patient with all this sort of vitamin D, calcium and all. She might we have to tell her that she'll have amenorrhea for a greater period of time, and that it might return back not with the 3 doses if she is taking, then it might not return back for even 2 years duration. So we have to counsel on that.
Fine. So, but DMPA like is the only one, I think, which we can't give immediate postpartum. We heard that we can give immediate postpartum. You can give the implant. You can give the LNG-IUS as a PPIUD also, but or the PPIUD. So you have options of giving immediate postpartum or post-placental, but not the DMPA that you really need to wait for 4 weeks. Some people say 6 weeks before, but at least that is a general idea. But a lot of people like DMPA. They, especially in the public health, as they would love to have one injection every 3 months rather than a IUCD or rather than a daily tablet. But again, as I said, it's a personal choice. But what we are here for is to check whether it fits into the medical thing.
Just to add one thing, Dr. Basar.
Yeah, please. Yes, please.
Like WHO and GOI guidelines, it says it is category 3 for less than 6 weeks in lactating women.
Yes.
But Western world, they do give, they don't have any forms about it. They FRSH guidelines doesn't actually categorize as category 3. It is 2 there. In India and WHO, it is 3 here. Of course.
Fine. So yes, ma'am. So Dr. Amrita, let's bring you in here. Women with migraine using a hormonal emergency contraceptive pill. Yes or no?
Yeah, I guess, sir, there's no contraindication of giving emergency contraceptive pills in any form of migraine. But yes, when we think about the other contraceptive pills, then it is a separate issue. There's a whole lot of criteria about it coming with COC and everything. But ECP can be given in migraine. I don't think
Yeah.
there's any
But the
contraindication.
migraine again issue, I think, was that aura and no aura and all those
Yes,
things
yes,
there.
that's there,
Because
but that's there with COCs and all, sir, mostly, but
yeah,
not with
COC is all, but
having.
but without aura, it is again category 2. You can give COCs in
yeah.
migraine. So you may give some baby steps of a 24/4 20 microgram ethernetran and see what happens
Yes.
before if it worsens the migraine or thing, then of course you can
Yeah.
stop. You can see that. Women with, I think, blood pressure we've already discussed, 150 by 96 on medication. So there's some people who have the false belief that having this medicine will increase your blood pressure. Dr. Amrita, would you like to comment on that?
What, sir? Again?
Having OCPs may increase your blood pressure, or people think that it raises the blood pressure because you're having the medicine. How true or false would that be?
No, sir, it doesn't increase the blood pressure per se. But yes, when we are thinking about like thrombogenesis and all, then CHC, yes, COC is coming in the. Hello.
Yeah, it was
Hello.
somebody.
Yeah,
Yes.
yeah. Then it is coming. We are coming in category 3 or category 4, maybe. But yes, with BP of 140, 150, 96, as we said that as we discussed, that we can like counsel the patient or give her the cafeteria choice and all the options and all the complication that could happen. Then we can regard it as category 2. I guess.
Yeah, and just one more point. I think that is also the reason when a person is long term on a oral contraception, you ask her to come back every 6 months or 1 year
Yes.
to make sure that her risk benefit ratio still remains benefits more than risk. So in that 6 month or 1 year, if she develops hypertension, if she develops some other problem, then you wouldn't possibly need to change or give her something else and offer her something different for the thing. Dr. Sushma, would you like to take this POP, progesterone-only pills for a woman with multiple risk factors of arterial cardiovascular disease? Would that be an option for you, or would you like to stay away from hormones totally, Dr.
POP is a very much safe contraceptive, and it can be, offered in most of the conditions. And this arterial CVD is one of them. You can easily prescribe it. It is category 2 there.
Yeah.
So,
Dr. Sushma, just want to hear from you. POP outside the context of a postpartum woman. So we understand that one of the largest use of progesterone-only pill is in the postpartum period. But besides that, we have heard, like as you rightly said, in this case, a lot of cases where estrogen is contraindicated. How much? What is your experience of using POP in those cases, and how do women tolerate breakthrough bleeding and spotting? If you would like to share, ma'am.
It has its own limitations actually, because till now it is not yet available in GI basket. Number one. Number two, it has timeline is strict. So there is a remember. You miss it, then of course you have to follow all the protocol related to tablets. So that is another thing. There are few contraindications also for POPs, like this deep vein thrombosis, and there are a few other conditions like a history of epilepsy and all. Because wherever and also where you are taking rifampicin or any enzyme inducers, so you need to be very taking the history very carefully as to before you prescribe POPs.
Thank you, ma'am. Dr. Meeta, we haven't heard from you in some time. Dr. Meeta, this is the case which we like to discuss here. It's a 35-year-old lady, possibly AUBL. She's seeking contraception. She has been found on sonography to have multiple fibroids without distortion of the endometrial cavity. And it's an AUBL case, a 35-year-old. We can assume she's parous. Her mother had also fibroids for which she had a hysterectomy. What is the contraception you can look at?
LNG IUCD, sir.
LNGIUS would be one good option. I think that would be definitely one of the options because it's not distorting the cavity. The other would be possibly you could look at ulipristal and mifepristone in a short term, and that also would be one option. Of course, the new oral GnRH analog also is there. A lot of people are playing with that. That's another play or toy which we have in our hands with one more. But yes, all said and done with the contraception per se, LNGIUS would be one of the choice, and a follow-up, of course, to see whether the fibroids are encroaching on the cavity and how she's responding to that. But if it's not encroaching on the cavity as we've put it in that case, that would be definitely be one choice which a lot of people would look at. Dr. Mukta, can we bring you here now? We want to hear from you, Mukta. This is the second case. It's a 30-year-old lady, irregular bleeding, wants contraception, mild acne, so going towards the PCO side and hirsute. So she has one pregnancy which she's aborted, and but she's now wanting contraception, little bit like PCO, irregular vaginal bleeding. So can we give her COC?
That's a safer choice, and preferably if we can have some COCs which have anti-androgenic effects like cyproterone, or drospirenone. So even that will be better for her hirsutism as well as for her acne.
Yeah, I think the non-contraceptive benefits which we so boastfully talk about do also come in here, where so many times we prescribe contraceptives not for birth control but for other reasons, and for bleeding control, for acne control, for PCO, and this again I think all of us would agree with you. So this is the other part of the thing. Dr. Amrita will bring you in here. This is the diabetes spectrum, which we know most of us don't see the 20-year duration diabetes. Most of these women would not be coming to us for contraception. They would be going to the medicine doctor for other complications of long-term diabetes. So the most of the time we would be seeing NIDDM and sometimes in insulin-dependent diabetes too. So what would be your choice of contraception in these cases?
So per se in diabetes, like even in the insulin dependent or non-insulin dependent, we can give all the contraception with ease because it comes in MEC 1 and 2 criteria. Yes, if there is nephropathy or something, then like we can't go for COC and CIC in that sense, and DIMPA also. But other than that, in both of insulin dependent and non-dependent, we can go for like.
Yeah, and Dr. Amrita, again, all of us do understand that diabetes may not be in isolation. It may be along with obesity, along with other things, which may tilt your balance on what you like to give. Prerna, you'd like to come in and comment, Prerna? Any comments on diabetes?
Diabetes per se is not a contraindication, definitely, but as Dr. Amrita has suggested, there can be some associated vasculopathy or nephropathy, or maybe. So we have to understand what about the vascular complications, the blood sugar control, how well monitor she is doing it, and how regular can she follow up with us, and all the cardiovascular risk explained to her in complete detail. So counseling is a very big key for these particular patients.
Maybe stay away from estrogen would be one thing if you have other things along with it, unless she's hell-bent to take estrogen, but stay away from estrogen could be one of the different things. Priya, any comments? Dr. Priya on diabetes?
Sir, I think whenever a patient of diabetes comes to us, suppose many a times we do get patient of these gestational diabetes being carried forward, like I do personally seek patient. In that cases, I prescribe usually all the contraceptives. But as rightly Dr. Amrita and Dr. Prerna has added, if a patient of microvascular complications is expected with diabetes, I try to safely counsel my patient on copper IUDs as my first choice. And then we go ahead with the POPs, LNGs, or implants. And definitely CRCs are being taken as the last resort or are tried not to be given.
Agree with you. LNGIUS in a woman at a high risk of acquiring HIV. Is it a good idea, Dr. Amrita?
Sir, yeah, there's like if high risk of, if there is like high grade of HIV of the disease of 2 and 3, then we should not go for LNGIUS for sure. But yes, again, it's a cafeteria choice, but yes, for HIV and all, it is mostly, sir, in fulminant cases of HIV, we don't give LNGIUS.
So basically, you're talking about how her risk of STIs are. If the STI risk is high, you have a chance of going from the lower genital tract to the upper genital reproductive tract. So
Yes.
that's what your general worry is here. So as long as
Yeah.
she's treated, as long as she's fine, as long she doesn't have multiple partners, as long as she's treated for HIV, she may be okay. But she may have other
Good.
choices at that point. I guess we all agree with you. Priya, yes, would you like to?
Yes.
Any points? Yeah.
Sir, in case when the patient is at high risk of HIV, so risk factor per se is not a contraindication for any of the modalities which are available to us. When the patient is only categorized at a high risk for HIV, we can offer all the contraception to such patients. But we have to really take care of the CD4 counts in a case of HIV, sir. If the
Correct.
CD4 counts are expected to be more than 200, then in such case, for first MEC, first criteria we take as implants, POPs, and the copper IUDs and LNG IUS are definitely categorized as MEC2. And
Fine.
if the counts are less than 200, sir, then if the continuation of the IUD or LNG IUS is there, we MEC2, but the initiation of a new LNG IUS or a copper IUD is definitely categorized as category 3 in a case of
Fair enough.
CD4 less than 200, sir.
Dr. Shushma, we'll come to you. DMPS subcute. There was a time when it was freely available. I'm not sure whether it's still available now in the private sector, not in the public sector. What do you think is the short and long-term future of DMPS subcute? One of the reasons why it came with a bang is because it was women user dependent. You do not need to have a healthcare provider to administer it. They can take shots themselves every 3 months. That was what was working in Africa. But would you try to bring in your perspective of DMPS subcute? Yes, ma'am.
So DMPS subcute has been introduced into public sector now. It is in the GI armamentarium, and it is a wonderful, option. It can be used from 15-year-old, 16-year-old to around 45 years old female. So again, the dose is lesser than the conventional one, IM one, and it is very easy to use, and it comes in a Uniject form, and it can be easily given. So there are hardly any, they're like whatever you talk about the bone density or blood changes, but these things are all theoretical. It actually goes away once it is stopped. So it is very much safe in young women, and they can have the control over unwanted pregnancies.
Sure.
Dr. Basa, time alert is coming up.
Yeah, we're just finishing. CHC, okay, I didn't know we spent 40 minutes like that. Okay, and it was, we thought we'll finish in 30. CHCUs in dyslipidemia, the last question. Mukta, would you like to come here and then we'll move on? We'll just go with the last one. We'll skip all that and then we'll go.
Those COCs are known to have effect on lipid metabolism. I think it belongs to MEC2 because the risk of harboring a pregnancy will be much then. So if a woman want, then benefit outweighs the risk, and we can give it to the women with dyslipidemia without having additional risk factors for CVD.
So we'll end with this app, the app which we're talking about, which Dr. Sushma also put. So this is the app which is there, the medical eligibility app. This is how it looks. So there is, so you have to just type in your app store WHO medical eligibility criteria. This will be the color dark blue of the thing there. It's very user friendly. So once you punch in what conditions are there, they can tell you the different devices which can be used, or different options which are there, and which is which criteria. So here you have punched migraine without aura, and here you are saying which age group she is in, and here you are having choices of POP, implants, and IUCD, and the which MEC criteria there is. So again, this is how this app looks. Contraception is the name of the app. This is how it looks on your screen. And this is not the light blue, the dark blue one is what we're talking about, WHO contraceptive tool. And this is what will once you download that, you can play around with it, and you will see there's several options of different medical conditions. And once you punch in the age of the woman and the medical condition, it'll come up as the options of contraception which are there for her, and what MEC criteria they fall in. And again, it's on the same thing here. Again, as we said, this comes up. Here is the different tools are there. Additional info how to use the tool in case you are not very sure. And also the age criteria, different age groups of how we can do. So carry home message just from my end before we take the messages from all our experts. Effect of an unattended or unwanted pregnancy in a woman with a medical disease often outweighs the effect of birth control on the disease. Careful history taking, as was pointed out by our experts, before offering contraception and guidance from the WHMEC app will help us deliver optimal care. Idea is to eliminate ignorance and fear in giving birth control options to women with medical diseases. Any parting thoughts before we end? Dr. Priya Gupta?
Dr. Basab, you are a wonderful moderator. This is my carry on message.
Yeah. Priya, parting thoughts, Dr. Sushma, all of us, parting thoughts
Yes.
before we end. Just the
Yeah,
last.
we had a wonderful, 40 minutes. How it just flew by. I just failed to understand. It was a wonderful, interacting with you and all my co-panelists. But I must say, Dr. Basab, you are a wonderful moderator.
Thank you, ma'am. Thank you.
I
Thank you.
too second, madam.
No,
Thank you,
that
sir.
that
Thank
was
you
that was
so
not the
much.
thing.
It was
We
a
wanted
wonderful
parting thoughts
panel.
on MEC criteria for yeah, Priya, please. And all the best,
Sir, it
Priya.
has to be taken definitely. Thank you, sir. Thank you so much, Parag sir.
Yeah, please. You muted. By mistake, yourself, you're muted.
Sorry, sir. The MEC has to be definitely incorporated into our practice in a day-to-day OPD and IPD dealing of the patients which are seeking us with the contraception care, but with a proper understanding of the disease and with a thorough history of the present scenario. Thank you, sir.
Yeah, thank you, Priya. Mukta, your thoughts, then we'll come down to Amrita and Priya. Yeah.
Let's make the choice of contraception free from the fear and apprehension for every woman.
Yeah, Amrita.
With all the discussion, the crux comes like in this era, the cafeteria choice is so much important with proper counseling of patient and with like letting them know all the complications and everything. We must follow this for our safety and for their safety.
Prerna, Dr. Prerna.
Definitely, as the theme of this webinar goes, a pregnancy by choice and not by chance. So we need to enhance the reproductive autonomy of our patients with individualized care and promoting effective family planning is should be the key to it.
Dr. Meeta Gupta. Yes, ma'am.
So it's all about counseling. Give extra 2 minutes for counseling, and the basket of contraception would be easily acceptable for each and every female. So just extra 2 minutes on our behalf. That is all we would request everybody.
I think a very good point taken. Dr. Sushma, your last words and then.
As a doctor, everybody should be carrying a stethoscope. Carries different machines. So laparoscope surgeon carries a stethoscope and those things around. Gynecologist should be carrying this MEC wheel with oneself. Yeah, that is a very useful, low cost tool.
Thank you, ma'am. Very well points, very well taken. Thank you for a brilliant discussion, and thank you, dear Parag, friend, and Shobha for this wonderful opportunity to interact. Thank you. Signing off.
Thank you, sir. Thank you so much.
Yeah. I think that was a wonderful take home that we can carry a MEC wheel, and thank you, Sushma, and thank you, Basab, for bringing that out from your panel. It's very good, very excellent.
We can continue discussing, but then let's have the post-test link because
yeah, correct. Yes. Yeah. So time is 10 minutes, no?
Yeah. So Shreya has already shared it.
Request all delegates to just go on to the post-test link and take your test and submit it ASAP. 10 minutes. It will last only for 10 minutes, then it will go away. Parag, if we continue discussing, it will disturb them actually. So
we can continue discussion after the
test. Yes.
There's no limit as to when to stop.
I know. Came out extremely well, Basab. So nice. Wonderful.
We all
Very
of
good.
you guys. No, it was a very, again, as I second, the nice, the curating of your faculty choice was very good. Topic choice was good. And all that helped,
That's why we
Yeah.
chose you as the model.
No. Like, no, it's not that.
No, no,
But it's just generally, it's just nice. Because people who are speaking on one thing again and again, they
no, the
usually.
goal of the moderator is to get what
It's
the
always a pleasure to catch out Basab, Sorry.
Either online or offline, it's always a pleasure, Shobha. And whenever we are there,
Anyway, yeah.
we'll love connecting. Okay, people are putting in there. Somebody has a problem with the link, Rag. Dr. Sudha Salana is not able to get the link. If you can, I think, ma'am, you have to scan the QR code here. Shreya has given it here.
Given the volume that we have, we can have so much of research potential in this field. It's real.
How can we scan this code if we are using our own phone?
Yes, Sanjay, you should have. Sanjay ji, hi.
How can Basav?
Huh?
I am using the phone only. How can I scan that?
Oh, in the phone. I don't think you can do that. You have to use another
So,
person's phone.
You should give something alternative for us.
you can click the link.
No,
Sanjay.
link. You should click the link.
Link दीजिए.
Link in the chat box.
Link है chat box में.
Sanjay
आप
sir,
link
you
पे
can
press करिए. The Google form will open. Yes.
Yes, got it. Thank you.
otherwise, Sanjay sir, you could also use your Google Lens to scan. That will also help.
नहीं वो कर रहे हैं ना अभी कर रहे हैं रुको.
मिल गया.
So what is absolutely heartening is the young people coming up and speaking for contraception, and really wonderful to see people like Rachna, Priya, Prerana, Meeta, so many young champions for contraception. Of course, Munjal. So
But
I
we
think
stopped doing the conferences on contraception, Shobha, long time. I remember we were doing a few when Ritu was there, and after that, nothing in our time, nothing in your time. Standalone contraception conferences are not there anymore.
Not there
We have one-day seminars and one-day things, but we had a good contraception conference, 2 days, hands-on, everything. We have to work on those directions somewhere.
When Ritu was chairperson, I remember.
They did 3, I think, but three in each year. She did 1, I think. She had 4 years, and each year, I think, Ritu did 2 at least. One in Calcutta, I remember ICC we had, and then there was one more, and there was so many contraception.
Very high perseverance by Ritu ma'am, really.
Wished her in a birthday day before yesterday.
Oh, really?
Also acknowledge that lot is gone after me. I just complain of overgrown workers and white collar terrorists. Right? They said no.
And Dr. Sudha, I think your net might be slow. Otherwise, link is being worked on by everybody else. So, can you check the Wi-Fi or use another device and try it out? Huh? Okay.
Yeah, ma'am's on a mobile. That's the same problem, no? Mobile problem. Durga has a nice backdrop, huh? Jagannath. This is the original Jagannath Dham, not not the Mamata Banerjee Jagannath Dham. Huh? Mamata Banerjee has got a Jagannath Dham, which nobody is going to.
There is one Jagannath Dham that is in the entire universe.
Yeah, that's good. Nah? You should tell her. Why didn't you tell her? She's making another Jagannath Dham in Digha and saying that this is also Jagannath, that is Jagannath. What is she doing? That's
Well, after the test is over, will you permit me a minute or two?
Turning to CC,
Of course,
You're the boss. You're the convener. Whatever you want to do, you do. It's your show.
They are saying that we are disturbing them, Dr.
Recommended approach.
We are disturbing them. Please.
We are giving exam.
So is the time over, host? How much more time? I can't see the timer because for the talks you had put the timer. Now I can't see the timer.
Ma'am, it's done. 10 minutes.
Time is over. Purple page 3. Is the time done?
Yes, ma'am. Time is over.
Okay. 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 We can inform them. That means the link will no longer work, right? Yeah. So you can you display the answers, please? You can quickly conclude then. And Dr. Durga Shankar Das, would you like to say a few words? Dr. Durga Shankar Das? Yeah.
Okay.
Yes, please.
Thank you.
Please.
So,
Yeah.
First of all, good evening to everybody. I'm so delighted to find to such a great participants under the able guidance of Parag nicely crafted topics by Dr. Shobha. So what I find that during the total day, that we have got a strong unmet need of contraception, and the major group is the younger population. So our task is huge. Thing is, out of all the topics, my cause of concern is adolescents, unmarried couples, and gender variants. I'd like to little bit add one line to the dual protection proposed by Dr. Colonel Sanjay Sharma, that this dual protection should also be extended to the unmarried couples, living in relationship, gender variations, transgenders and all. Because in modern day practice, this faithful homologous relationship is practically highly unpredictable. So we must counsel them, and particularly all adolescents girls, that they must use dual protection and never disclose that they are using a contraceptive. She is using a contraceptive on her part to her partner, and always insist her partner to use barrier and condom. She should never expose the second protection she is using for her. This should be the same message for the living relationship as well as to the unmarried couples. One thing I will like to highlight here, because of my personal experience, at the time of counseling, always insist that they must take hepatitis vaccination. The example which the Colonel Sharma gave, that a very well educated lady had a relationship before her marriage, and with one stroke of her relationship, she contracted HIV. It should be known, contacting HIV in one sexual intercourse is far away. It is 1 into 200, whereas it is 1 in 30 in case of hepatitis B. Please, please, please insist everybody at the counseling first to take hepatitis B vaccine. This is my pure and personal opinion. Then another 2 or 3 things very well mentioned by Dr. Mrinalini, that post-abortal, she says that after 15 days, I will be insisting to come for a checkup, and it is better in private setup. It's absolutely true. I have observed that. But I have a deep pain to say, when there is a robust follow-up program on the part of government, why is it failing in private practice? It is improving. That means what Manju Madam told, if we cannot measure the gap, we cannot explore, we cannot succeed. So there is a gap. And what I feel is, in my practice as a peripheral gynecologist, that there is lack of willingness on the part of follow-up staffs and lack of audit. So another comment given by Manju Madam also, that why not pediatricians should be involved. I think this should be one of our topmost priority, because sexual exposure very well occurs nowadays within the age group of
Very
pediatricians.
true. Correct.
Well,
Yeah.
of my comments. So now it is up to Shobha.
Thank you so much, Dr. Durgadas. Very valuable inputs. Can we quickly share the answers? And post, please note that some are still struggling to submit the responses. Can you keep the link active in the chat box for a few more minutes? Is it possible? Yes or no? Yes? Yes?
I think, no, ma'am, its time is over now. It's
No,
10
if you
minutes
can.
already.
No,
Yes.
I know that. I know it, but some have
If you want,
probably.
then I will.
Hmm?
If
No,
you
just no. You just identify those who are asking and give it to them. No, as individual.
Okay, ma'am. I thought
Try
you
no,
need
please. No,
Okay.
because unless they submit, then they will not get the certificate. No, that defeats the purpose. So
Okay,
see, 3 or 4 people have told. You'd see in the chat box very carefully
ma'am.
and share the link to them, or make it a policy matter and share it for another 5 minutes. Everybody will submit. What is there? I
Okay,
am
ma'am.
telling you, no.
Okay, ma'am.
Please do it. Please.
Yes,
We
ma'am.
want everybody to submit responses because some of them could not open it initially. So we have to give that time grace. Okay.
ma'am.
And share the answers. Meanwhile, they are submitting, they have completed, they are not able to submit. So it's okay to give the answers. Please share the answers. It is very late. Please share the answers. Yeah.
Okay, ma'am.
Rachna, please read them out. Yes, Rachna.
Yeah. So for the day one MCQ certificate course, statement accurately describes the purpose of medical eligibility criteria for contraception. The option was B. It is to provide guidance on which contraceptive methods are appropriate for individuals based on their health status and other factors. Now, question number 2. Which of the following contraceptive methods provides the most effective protection against both pregnancy and sexually transmitted diseases? So the answer was male condom with combined oral contraceptive pills. That is option C. Then according to CDC and WHO guidelines, what is recommended approach for women at high risk of STIs who desire long-acting reversible contraception? So option is C. Proceed with IUCD insertion if patient is asymptomatic and screen her concurrently. Question number 4. What is the primary purpose of MEC for contraceptive use? So the primary purpose is to identify contraindications for contraceptive use. It is the primary purpose. Option B. According to the MEC criteria, which of the following conditions would be classified as category 4, that is unacceptable for health risk for combined hormonal contraceptive use? So answer will be history of deep vein thrombosis, option B. Which of the following contraceptive methods is generally considered safe for women with a history of breast cancer? So the option among the options, it is the copper intrauterine devices, which is safe in women with history of breast cancer. Question number 7. What is MEC category for women with uncontrolled hypertension using COCs? So the answer will be category 4, that is unacceptable health risk. Question number 8. Which of the following is a consideration when choosing a post-abortal contraceptive method? So the options were the availability of method at the healthcare facility, the cost of different methods, the woman's preference and individual circumstances, and all of the above. So the answer is all of the above. Can we scroll the slide? So emergency contraception can be provided from pregnancy as many as 120 hours after unprotected or inadequately protected intercourse, and should be made available to all adolescents routinely. So the answer was, so this is a false statement. It is to be given within 72. Which contraceptive methods cannot be prescribed to adolescent age group? So combined oral contraceptive pills, barrier contraceptives, IUCDs, or all can be prescribed. So all of them can be prescribed to adolescent age group. What percent of survey response adolescent girls 14 to 17 years of age expressed interest in and supported access to over-the-counter oral contraceptives? According to a survey conducted by investigators of the Jane Fonda Center for Adolescent Reproductive Health. So the survey says it is 73%. Option D. Which of the following is primary mechanism by which COCs prevent pregnancy? So the option is C. It inhibits ovulation via suppression of the FSH and LH hormones. Question number 13. A 35-year-old woman who smokes 1 pack of cigarettes daily is considering of starting COCs. What is the most appropriate clinical advice you can give to her? You can ask her to switch on to the progestin-only pill, that is option B. Which of the following progestins used in oral contraceptives has anti-androgenic properties? So it is drospirenone, which has anti-androgenic properties, option C. What percentage of transgender males stop menstruating after 6 months of testosterone? So the percentage is as high as 80 to 90%, option C. Can we scroll? What is the impact of testosterone on ovaries of transgender males? So it causes ovarian follicle counts. Ovarian follicle counts are similar between testosterone exposed and non-exposed ovaries. So the option is B. What are the perceived barriers for use of contraception by transgender men and assigned female / intersex at birth? So inadequate counseling regarding contraception provided by the care provider to transgender men, non-binary individuals and individuals with differences in sex development, the misconception that taking testosterone prevents pregnancy, apprehension that contraceptive pills will interfere with masculinizing effect of testosterone, and all of the above. So all of the above are perceived as barriers for use of contraception. That is option D. The WHO recommendation for inter-pregnancy interval is 2 years. As per National Family Planning Health, what percentage of birth occurs within 2 years of preceding birth in India? So the option is 25 to 30%. And last question, windows of opportunity for counseling for postpartum contraception include antenatal period, postnatal period, up to 6 weeks, up to 12 months after childbirth, and all of the above. So the answer is all of the above. So this concludes with the answers for the post test. I will now request Shobha Madam to give concluding remarks for
Yeah,
today's.
I think today's session was very well received and wonderful deliberations. I think you agree with me, Rachna and Dr. Durga Shankar, and all have hugely benefited. I am very sure. Nivedita Datta is there, dear friend, and so many others. Anybody wants to say any one thing before we completely log out? Hi, Nivedita, kaisi hai? Okay, so one concern is that few of them have not submitted the answers, and the link unfortunately could not be reactivated again because the office is not able to do that. It lasts only for 10 minutes. We are sorry that you have been put to this inconvenience. Hopefully tomorrow and day after it gets compensated, and there will not be any problem eventually. I think that is okay. Anything else you want to say, Rachna? Sunita ji, any concluding remarks? Thank you for staying till the end. That's wonderful.
Please unmute yourself, Sunita Madam.
Yeah, thanks a lot. It was a wonderful session. It was fantastic, absolutely. The conceptualization is very good. Obviously, you had excellent speakers, experts, and panelists. I don't know, certificate or no certificate, I just think it was a great learning session. More important, I think most of us can go back with the take-home message that contraception should be a part and parcel of every obstetrician's armamentarium, the MEC, as well as every woman should have a right to contraception. That is, someone just mentioned that contraception should be like vaccination. Just keep promoting it so that we can get 100% contraception and zero unmet need.
Sunita ji, आप कुछ कहेंगे? Absolutely, it is like vaccination. I agree with Nivedita. Yeah.
From Viramji and from Hussain, that why have we not been
You are muted actually.
What is the duration of this session?
Trying to analyze too much about the possibilities to do something like this.
Sunita ji, नहीं हो रहा है. अच्छा चलो. Okay then. Okay then. With that, we conclude today's session. And please join us.
I think it's now allowed by you.
Okay.
So just 1 minute. Congratulations for this wonderful plan of this 3-day contraceptive workshop. I just want to suggest that if you can follow it up with some kind of practicum which can be held at different varied a regional practicum on the contraceptive methods, the skills involved. If you can follow it up with that, that will be a wonderful thing. I can't hear you now.
I think those who have spent a lifetime in this service, real value add-on for our program, Dr. Sunita. And you are the one who has created so many modules for the government training and really worthwhile having you on the session. And there are some concerns. Dr. Chelapan Karupaya, especially, I'm so sorry, we stand corrected. I think we did not follow some norms. We did have a little bit of delay in starting the sessions and we got delayed. So we will cut off the initial formalities tomorrow because it is day 2. So please do join tomorrow and make this a success, because we must thank the audience for their patience and for their passion for learning this subject. And really grateful that all of you stayed till the end and took the test. Thank you very much. See you tomorrow.
Thank you.
Yeah. Host can end the session.
We can end the session now, and we'll make sure that tomorrow we are following the protocol and the time.
Yeah.
Everyone for joining in.
Yeah,
So,
thank you, Rachna. Everybody's cooperation is needed for that. Thanks a lot.
Thank you.